Now we just need to keep this picture in our mind, like what is this? That's all, right? Because other things already should be in your mind, right? Treatment and other things under another topic, right? Imagine today we are just identify the images. That's only okay, and some other important details I have added. So let's start, right? Yeah. That's why I told in the beginning, because if you are like asking like one by one, so what is the treatment, other things, so then we can't do this, right? Because today the topic is imaging, right? So we will go through images only. Okay, yeah. So let's start. 1 minute. Yeah. Okay, so let's start from the chest X-ray, right? This is one of most important topic, and you should know how normal chest X-ray present, right? So everyone know here number one is trachea, right? Number one is hilum, right? Here in the both side. Then number three, what is those? Lungs, right? In both side lungs. Then number four, what is this? This is diaphragm here. This side diaphragm. Then so what is number five? It's heart, right? Doctor's heart. And number six, this is aortic knuckle. Aortic knuckle. Please remember this one. Then ribs and scapula, right? Where's number eight here? Scapula, backside. Then breast here you can see in here number 10, bowel gas. So this is the normal chest X-ray anatomy, right? First of all, you should know about this normal chest X-ray anatomy. Then you can easily identify the abnormalities, right, doctors? Yeah, here also the same thing, trachea and everything. I'm not going to discuss one by one. This everything is for normal anatomy. Okay, and you should know, like when we discuss about the chest X-ray, you should know what is the upper zone of the chest, middle zone, and lower zone, right? Lower zone. Then you all know left lung divided into two parts, upper lobe and lower lobe by oblique fissure, and right lung divided into three parts, right? We have what? Upper lobe, middle lobe, and lower lobe, right? We have oblique fissure and we have horizontal fissure. Yeah. Okay, I'm not going to discuss like too much. We'll discuss from the abnormalities, right? Abnormalities. Yeah. So let's discuss about from the pneumothorax. So how pneumothorax is present, doctors? Tell me how it present. What are the things that we can see in chest X-ray? Tell me. Tell me, doctors. What we can see. Okay, collapsed lung, disappearing bronchovascular pattern, white line pushed. Okay, white line pushed lung. Okay, yeah. Here, what we can see. Okay, I'll show. So here we can see the collapsed lung, right? So we can see collapsed line, right? And we can see the pleural white lines. Can you see here the small white line? Here there's a small white line. So we call it pleural white sign. So, and we can see collapsed lung, right, doctors? Okay, we'll see. And here also, here you can see this white line right here. Yeah. Okay, so here, okay, this is a good diagram. So let's discuss how tension pneumothorax present. Here, what we can see, doctors, in tension pneumothorax. Here, what you can see. Sorry. What you can see in here. Yes, tracheal deviation, right? Tracheal deviation to which side, doctors? In pneumothorax, trachea is deviation to which side? Yes, healthy side, right? Or opposite side from the pneumothorax. Here, this is the pneumothorax part, right? You can see very dark appearance, right? Here left hemothorax is black due to air in the pleural cavity. So in chest X-ray, air is defined from the black color, right, doctors? Air is defined as the black color. We all know that here. So here dark black color area mean what? There is a left hemithorax is black due to air in the pleural cavity here. Hemithorax, right? So here, signs of tension. The left lung is completely compressed. Arrowhead here. The lung is completely compressed, right? Here, can you see? Left lung is in here and completely compressed. The trachea is pushed to the right. Arrow here. The trachea is pushed to the right because that is the unaffected side, because the affected side is left side, right? Yeah. The heart is shifted to the contralateral side. Note that the heart border is pushed to the right, red line here. Heart also pushed by this pressure, right? Because air is trapped inside and it's make the force to these lungs and heart, right? And trachea as well. So you can see then what else? The left hemidiaphragm is depressed in orange color here. The diaphragm is also going down due to this pressure, right? Yeah. So please remember, this is a tension pneumothorax. And you all know about how this is also another example for large pneumothorax. Here, along with the symptoms such as breathlessness, establishing the size of pneumothorax help determine the management, right? Okay, so pneumothoraces are managed in accordance with the, no need to read that. Here, this chest X-ray shows the large pneumothorax. Here, P. This is the pneumothorax area, right? Pneumothorax greater than 2 centimeter at the level of hilum. Here, 2 centimeter, right, doctors? More than 2 centimeter, right? Yeah. Then this chest X-ray shows the large pneumothorax P, which is more than 2 centimeter depth at the level of hilum, right? Yeah. Here. Then here is the lung edges, like that. It's a very large one. And how we can see pneumothorax in CT? Here, pneumothorax in CT, how can we see? Here, this is the red area. This is the pneumothorax. Air trapped here, right? In the exam, they are not given in this red color thing, okay? In this diagram, they have like easily identified. That's why they have marked it as in red color, okay? Here, then curved arrow mean the compressed lung segment. Because of this air trap, this make the pressure towards to the lung, and the lung is here collapsed, right? Here you can see the full lung proper, right? But in here, due to this red area, due to this air, the lung is pushed down and collapsed, right? Here, can you see? Yeah. So that is how you can see. That's also the pneumothorax. Here also a small pneumothorax here. Okay. Then discuss about hemothorax. So how hemothorax present, doctors? How hemothorax present? Mm-hmm. Tell me. Usually hemothorax presented with some injury, right? Some trauma, road vehicle accident, right? With flyer chest, right? Or some cases they everything is present with him, like usually with the road accident, or in history they have given some injury or some trauma, right? And most of the cases these hemothorax and pneumothorax are present at the same time, and we call it hemopneumothorax, right? We will explain. So hemothorax, blood enter into the pleural cavity most commonly occurring following chest trauma, and hemopneumothorax is the both blood and air within the pleural cavity, usually occurring after the trauma. So here also blood in pleural cavity. It can see as here blood in pleural cavity. Here blood in pleural cavity, and upper side air also trapped in pleural cavity. Here only blood. So how it presents? So what are the X-ray signs that you can see, doctors? That you can see? Mm-hmm. Yes. You can see which sign, doctors. You can see which sign. Mm-hmm. Yeah, here you can see this meniscus of fluid blunting in the crostophrenic angle, right? Fluid blunting in the crostophrenic angle. Here, diaphragmatic surface and tracking up the pleural margin of the chest wall. Here, you can see the meniscus sign. I'll show here. It's a good one here with the fracture. Here, where's the rib fracture, doctors? Where's the rib fracture? Here is the rib fracture, right? Rib fracture. Here, rib fracture with hemothorax. In the contrast of just a trauma with rib fracture of a pleural effusion is likely to be a hemothorax. Here, you can see hemothorax with this meniscus sign, right? Here, right. Okay, then this is the this is the hemopneumothorax, right? Here you can see pneumothorax in this part, and here you can see hemothorax as well. Both are present in same scenario, and this is the rib fracture, right? Here is the rib fracture, right, doctors? Yeah. So hemopneumothorax. Please remember here pneumothorax, here hemothorax. And what else? Here also same thing they have mentioned about this meniscal sign here. Okay, yeah. Then tell me how pulmonary TB present. How pulmonary TB present? How pulmonary TB? Pulmonary TB also we have different types, right? Primary TB, right, doctors? Different types. Mm-hmm. Yeah. Okay. Let's discuss about primary TB. How it present. So here there is a consolidation and highlight enlargement we can see. So there are no radiological features which are themselves diagnostic of primary TB, right? But chest X-ray may provide some clues to diagnose, right? Like these are not very specific, right? Because we can see consolidation in where? We can see consolidation in pneumonia cell, right? And we can see highly enlargement in where sarcoidosis as well, right? They are not very specific, right, doctors? Yeah, they are not very specific, but like with other features. So, what are the TB features, doctors? Tuberculosis features? How patient present with TB? Usually, patient with history, right? Some history. Okay, weight loss, cough, sweating, right? What else? Anorexia, right? Sweating at night. Okay, yeah, 1 minute. What else, doctors? And you should know about all the tests, right? How we should identify these acute TB, right? Acute TB and what? Acute TB and latent TB, right? Doctors, you should know about the diagnostic criteria, right? Doctors, diagnostic criteria. Okay. And you should know about the isolation requirement as well. Okay, in 2025 September, they have asked about this isolation requirements as well. I have explained those in our theory class as well. So please remember, please go through it. Okay, yeah. Okay, here. Yeah. Then in post-primary TB, there can be a lung cavity, right? Here, you can see like ring-shaped, here ring-shaped appearance, and if the patient is post TB, so we can think about lung cavity, right, doctors? Usually, same patient as image above. 4 months later, here this patient 4 months later, cavities are common finding in this TB infection, right? Yeah. Then what else here? And post-primary TB. Here, post-primary TB. is the most common immunocompromised individuals, for example, those with HIV and immunosuppression or immunosuppression drugs, or those with malnutrition or diabetes. The upper lobe is more commonly affected here. You can see, right? Here, atypical consolidation in the upper lobe, right? Yeah. The highest structure may be disordered due to the volume of loss in upper lobe. Consolidation often extended to the hilum. Here, they extended to the hilum as well. Here, you can see. Now, in February, they have asked a question. Just we got the recaller version, like lower lobe pneumonia, chest X-ray only, right? So you should know about how these lobe pneumonia presented, right? So here, what you can see, which lobe is affected, doctors here. Which lobe is affected? Yeah, yes, left side up. Here, not left side, right, doctor? Here, right side, right? Yeah, yeah, right side. The right side upper lobe, right? Yes. Here. So what you can see in consolidation, doctors, what you can see? There's usually consolidation is typical for pneumonia, right, doctors? Pneumonia. Okay, here. What you can see? Right middle lobe consolidation, right middle lobe consolidation here. Then here, right lower lobe consolidation here. Can see. Yeah. Okay, and sometimes pneumonia is white opacities, yes. Okay, so in sometimes pneumonia can be complicated with pleural effusion, right? If they present like this, you can see this effusion signs as well here. I will explain about pleural effusion. Don't worry. Yeah, I just added this picture to get an idea, right? You all know after with the pneumonia, there can be what? There can be pleural effusion as well, right? Yeah. Okay, we call it parapneumatic effusion, right? Yeah. Now tell me how bronchopneumonia is appeared, how bronchopneumonia is present, how this bronchopneumonia is present, doctors? This one we will edit later. So bronchopneumonia is precipitated by inhalation or rarely hematogenous spread of a causative organisms that result in peribronchial inflammation, which can spread through the pores of corn to create consolidation throughout an erratic secondary pulmonary lobe. So let's see what we can see in this bronchopneumonia. It's different, okay? It's different, okay. Diffuse infiltrate, yes. And so here, in plain radiograph, bronchopneumonia is characteristic by multiple small nodular or reticular opacities which tend to be patchy or confluent, right? This represent area of the lung where there are patches of inflammation separated normal lung parenchyma, right, doctors? Yeah, these are the examples: Staphylococcus aureus, Klebsiella, Haemophilus influenza, Pseudomonas aeruginosa, E. coli, anaerobes like Proteus species, right? Here you can see it. Here, patchy airspace opacities throughout the right lung, here throughout the right lung, keeping with bronchopneumonia here. You can see in this right lung bronchopneumonia. Here, right lung. So where we can see bilateral infiltrations or bilateral patchy infiltrations, where we can see, doctors, give me example. It's atypical pneumonia. So give me the best example. Name of the organisms. Yes, main one is mycoplasma, right? Mycoplasma. Yes, doctors. I'll show the picture as well. Okay. This is bronchopneumonia. Okay, this is bronchopneumonia. In here, this is only Right side, okay, right side. But in atypical cases, they are bilateral, right? Yeah, bilateral. Okay, so let's see about atypical pneumonia. Here, what is happening with, okay, here I have added only the mycoplasma one because they are usually asking from this mycoplasma pneumonia. See here, you can see bilateral patchy infiltrates, right? Patchy infiltrates here. Bilateral patchy infiltrates. So tell me, what are the clinical features of atypical pneumonia? Clinical features of atypical pneumonia. Okay. Dry cough, low grade fever. Mm-hmm. Yeah, headache, and there can be atypical symptoms, right? Like generally, if we discuss about, there can be diarrhea, headache, right? Confusion, yeah, good, good. So where we can specifically see the diarrhea, doctors, diarrhea, yeah, mild gas, yeah, diarrhea in Legionella cases, right? Now tell me, what is the treatment of choice for the atypical pneumonia in generally common? Okay, good. Doxycycline, right? Doxycycline, yeah, main drug. And if it is not working, we can go with clarithromycin, right? Yesterday, not yesterday, day before yesterday also, I have explained it, right? Okay. So, yeah, the same here, the same here, also the same doctors. Here, patchy lung opacity is in the lower lobes bilaterally. Yeah. Then now tell me how you can see, sorry, fibrosis. Fibrosis, how you can see, doctors, in chest X-rays. Fibrosis, how you can see. Mm-hmm. Yes, good. Here, what you can see. You can see the reticular shadowing, right? Reticular shadowing here. Pulmonary fibrosis causes reticular, that means net-like shadowing of the lung peripheries, which is typically more prominent towards the lung base. Here, you can see. It may cause contour of the heart to be less distinct or shaggy. Chest X-ray can be helpful in monitoring the progression of pulmonary fibrosis. Okay, so what do you know about chest CT in these fibrotic diseases? What are the appearances that we can see in chest CT? CT, we have main two things, right? We have honeycomb appearance and what else? Yeah, honeycomb appearance, and we have ground glass opacity, right? Ground glass opacity. Okay, so now tell me where we can see this honeycomb appearance. Honeycomb, okay, sorry. Okay, so what is the main disease? This mic is on. Just one minute. Okay, are you sure about these answers? Okay, bronchiectasis. Okay, what else like mainly where you can see other than bronchiectasis? Yes, idiopathic pulmonary fibrosis, right, doctors? Mhm. Yes, interstitial lung diseases, right? Specifically. Okay, so please remember. Okay, I'll show. Yes, something else you should remember. about this ground glass opacity and honeycombing, right? So this honeycombing usually appear in very severe cases, like that means the late fibrotic stage, right? Here cystic or air spaces can be seen. Vessels are not visible in honeycombing, and this is stage is like late fibrotic, right? Reversibility, this is not not reversible, right? Here, idiopathic pulmonary fibrosis is the best example. So, where we can see ground glass opacity, the appearance is hazy opacity, right? You can see, and here this is a less severe case, right? Less severe case, doctors. Less severe case, right? Yeah. So, visible vessels can be seen, and disease stage is earlier stages, right? And here in sarcoidosis also usually we can see this ground glass opacity. Why? The sarcoidosis is most of the cases they are asymptomatic and not like it will take so long to progress into these fibrosis, right? These fibrosis, because of that, the most common feature is in sarcoidosis also this ground glass opacity. I'm just discussing about CT, okay? Not chest X-ray, right? CT now. Okay, reversibility, often reversible here. So we can see in ground glass opacity, pneumonia, RDS, right? So what are the other diseases I have added? Okay, I'll show. No, I have not added actually. So what are the examples, doctors? It is like usually from infection or inflammation, we can see these ground glass opacities, right? Minute. Mm-hmm. Yes, good. Yeah, usually pneumonia, right? Then pulmonary edema, acute respiratory distress syndrome, right? Hypersensitivity pneumonitis in acute stage, right? Because hypersensitivity pneumonitis also usually like due to what? Due to some exposure to some triggers, right? Some antigens, right? So in that case also we can see ground glass pattern because it's a acute situations, right? Yeah. And the early stages of these interstitial lung diseases, right? Yeah. Okay, so remember just so ground glass opacity we can see in infection and inflammations. So honeycomb, that's a severe form that we can see like fully fibrosed or end stage of lung fibrosis. Okay, what is this, doctors? What is this? This is what honeycomb or ground glass opacity. Yeah, honeycomb, right? But we can see the cystic appearance here, the cystic air spaces, right? Cystic air spaces. So here, numerous layers of honeycomb cyst in subpleural distribution, predominantly in bibasal zone. So, honeycomb cysts are exuberant and large confluent and can also seen in the subpleural locations in both upper and mid lung zones, right? Bronchivascular regions of both upper and lower lobes are also involved in the honeycomb. Just keep in your mind. So what you should need to know to if you see a honeycomb in the exam, remember that this is the very late stage of fibrosis, right? Late stage of fibrosis, and this is not reversible, right? Remember those things, okay? Yeah. Then this is the actual lung after pathology, okay? After pathology of fear, yeah, honeycomb lung. This is the end stage of this idiopathic pulmonary fibrosis disease. Okay, yeah, you can see honeycomb appearance. This is the exact same thing we can see in here, this cystic appearance, right? Okay, so what is it, doctors? What is this one? Here also honeycomb appearance, right? Yeah, okay. So what is this, doctor? So what is this? What is this? This is ground glass opacities, right? This is ground glass opacities, right, doctor? Here. Okay, what we can see in here, doctors? Here you can see hazy opacities, right? Hazy opacities in early fibrosis, so inflammatory or infectious cases you can see, and this is often reversible, right? Here we can't see those large cystic spaces, right? Just like some opacities you can see here. This is the early stage of SARS-CoV-2 disease. Yeah, here. This is a COVID-19 patients early stage disease. So now tell me what we can see in sarcoidosis chest X-ray. Sarcoidosis chest X-ray, what you can see, doctors? Bilateral hilar lymphoadenopathy, right? Bilateral hilar lymph here. Chest radiographs have been the mainstay of staging thoracic sarcoidosis for many decades with fair intra-observer concordance. However, this like here, sarcoidosis also chest X-ray also showing what there are different stages, right? Different stages of sarcoidosis. So let's see how it presents. So stage zero. Here, stage zero means there's no lung problems, right? So stage one, hilar or mediastinal nodal enlargement can see here stage one. Bilateral hilar nodal enlargement you can see. So stage two, nodal enlargement and parenchymal disease you can see. Here nodal enlargement and parenchymal disease you can see. It's not very clear. We'll see from here. So stage 3, parenchymal disease only here. The parenchymal fibrosis can be seen. The stage 4 and stage lung. So what we can see here, fibrosis, reticular fibrosis, you can see reticular shadow right here. It's a very severe case, right? Fibrosis, fibrotic lung, you can see. In this case, you can see what? You can see honeycomb appearance in CT as well. But in this case, you can't see this honeycomb appearance. You can see ground glass opacities, right? Yeah. Okay, that's all. So now tell me how COPD present in chest X-ray? How COPD present in chest X-ray? Tell me, doctors. Okay, it's hyperinflated lung. Mm-hmm. Okay, flat diaphragm. What else? Elongated lungs. Yes, yes, good. You know, right? Here, what you can see in this diagram. Here, doctors. Here, diaphragm is flat, right? Here, it is getting flat here. In normal subject, in the diaphragm intersect by fifth to seventh anterior ribs in the mid-clavicular line. Mid-clavicular line. Here, it is often difficult to see the ribs in patient with COPD as they are osteopenic due to long term of steroid use as in this patient. In this image, the seventh ribs, which are only just visible, intersect in the diaphragm here. Intersects in the diaphragm, red line here. Diaphragm level with the mid clavicular line. So the lungs is hyper expanded. So patient position and use of accessory muscles of respiratory can influence the anatomical positioning of the ribs on the chest X-ray. Flattening of the diaphragm is often a more reliable feature of lung hyper expansion. The green dotted here, the green dotted line indicate the predicted normal diaphragmatic shape and position, right? Yeah, this is how it present. Right, doctors? Yeah. Mm-hmm. Okay. Here, COPD flow. No need to get idea about this one. The floating. No, you know the main features. And here, COPD infective exacerbation. Okay, now tell me what is the criteria for starting antibiotic in COPD exacerbation? Yes, barrel chest also can be seen. You are correct, doctors. Yeah, now tell me. Mhm. So, what is the exacerbation patient with COPD? What is the criteria that you should fulfill to give antibiotics? Quickly answer me. We have discussed. Okay, ICU. Mm-hmm. In ICU, increase the sputum volume. Okay, ICU one is the main indication. Then you have to think about sputum purulence, right? If it's sputum purulence present with increased volume or with dyspnea, right? You have to consider antibiotic, right? Yeah. Remember these points, okay? Yesterday we just discussed. So what is Bula, doctor? So what is Bula? What is Bula in COPD? Yesterday, that day also I have explained. What is Bula in COPD? Mm-hmm. Air filled, yeah, pocket-like things, right? Air filled spaces, right? Air filled spaces in the lung, like usually more than 1 centimeter. Why? Because due to destruction of the alveolar due to emphysema, right? Emphysema, because in COPD, one of main categories emphysema, right? Emphysema. So because of that, there can be a bulla we can see. Yeah. Okay, there are. And yeah, here we can see some, it's not very clear, but here we can see it. Okay. Okay, next. So how lung cavity or abscess present, doctors? Lung cavity or abscess present, tell me. So how lung cavity we can see? Okay. Gas fluid level. So we can see ring shaped appearance, right? Ring shaped appearance, right, doctors? Here the classic appearance of pulmonary abscess is cavity containing gas fluid level, right? So abscesses are round in shape and appear similar in both frontal and lateral projection. Additionally, all margins are equal well seen, although adjacent consolidation may be make the assessment of this difficult. Okay, so let's see how it present. So what you can see in here, doctors? What you can see in here? Here you can see the ring shape appearance with air and what? Yes, yes. Air and fluid level, right? Here you can clearly see, right? Yeah. Okay, then what else we can see? Here, doctors. Here they have mentioned very clearly here. This lung abscess with gas fluid level. This pattern had a history of breast cancer It would be yeah, breast cancer. The cavity was an abscess which arose due to the patients being immunocompromised by chemotherapy drugs. A fluid level represent a collection of pus in the abscess here. AR and AR we all know in black color, right? Here, fluid level in here. So round appearance, right? Yeah. So here also you can see not very clear, I think because of the watermark here. Lung cavity abscess. Yeah. The patient has a lung cavity which was initially thought to be a cancer, but which disappears after course of antibiotics. Here, the ring shape appearance, right? Yeah. So now tell me how asbestosis can be present in chest X-ray. Asbestosis. Which depositions? Yeah, asbestosis you can see very clearly like this. Okay, here calcified plaques are associated with previous exposure to asbestosis and are almost invariably asymptomatic. Here you can see what calcified plaques, right? Calcified plaques you can see here. Here also, here, 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 calcified plaques. They appear as irregular shaped area of calcified density as white as bones because they are calcified, right? And should not be mistaken for area of consolidation. Pleural plaques are a benign entity, do not lead to the cancer or mesothelioma, and their presence does not equate to the diagnosis of asbestosis. So, asbestosis is fibrosis of lung caused by the presence of asbestosis fibers in the lung themselves. It may have similar appearance to fibrosis seen in previous pages, right? Yeah. And remember, they have like a good calcified plaque. So now tell me how pleural effusion can be seen. Pleural effusion. You know, right? How pleural effusion? Yeah, hemothorax also kind of pleural effusion, right? Yeah. The only thing is in hemothorax, it's blood, right? Here, there can be any liquid in like effusion. Oh, sorry. It's the, yes, okay, here. Yeah, can be seen. I'll show a picture. This is a asymmetrical pleural effusion here. So you can see the large pleural effusion here, and you can see this meniscal sign as well here. Can you see here? Yeah, like that. Here, remember this picture. Very good one. Meniscus sign. Here also large pleural effusion here with meniscal sign here. You can see large effusion. Okay, now tell me how pericardial effusion present. How pericardial effusion present, doctors? Good. Yes, water bottle sign, right? Yeah, doctors, very good. I have explained these things in our cardiac tamponade and pericardial effusion topic, okay? While we were discussing about cardiovascular system. Yeah, this is the typical presentation of what pericardial effusion. Please remember this bottle, okay? This type of bottle, okay? Here you can see this what pericardial effusion, right? Here also you can see this bottle appearance, right? This kind of bottle. Here also you can see. Okay, then here also enlarged globular heart, pericardial effusion. Okay, then yeah, like this here also same. They have mentioned about the malignant. There can be any different reason, right, for the pericardial effusion, right, doctors? Yeah, and here they have mentioned this patient with metastatic disease from primary colon cancer and has an enlarged and globular shaped heart due to malignant pericardial effusion, fluid and cancerous cells within the pericardium. Okay, yeah, here you can see. Then now tell me how lung cancer present. It shows the some dense area right here. Chest X-ray showing a tumor in the lung. Here you can see the irregular shape right here also. Here cavitated lung mass. Here this lung mass has cavitations as well. Here lung mass. Here CT also the same CT from this one like that. Okay. Then how cardiomegaly is present? Cardiomegaly is present, doctors. How cardiomegaly is present? Tell me, doctors. Mm-hmm. Okay, boat-shaped heart is present in where, doctors? Tell me, boat-shaped heart present in where? Tetralogy of palate, right? I'll show. Here, do you remember this picture? This picture here, this is boat-shaped heart. You can see in tetralogy of palate, okay? So don't confuse, okay? Yeah, don't confuse. So here, what we can see, what we can see, boat-shaped in TOF, good. Mm-hmm. Yeah, you should think about cardiothoracic ratio, right? The cardiothoracic ratio is increased here. The cardiothoracic ratio in here, 68%. So this is the cardiac width, this is the thoracic width, right? This ratio is increased here. It's usually here 68%. In here this is a mild case, it is 53%, right? 53%. Okay, so now tell me, what is the normal ratio of cardiothoracic? So normal ratio of this cardiothoracic, the ratio. Tell me, what is it? I should know, right? Mm-hmm. Yes, it should be less than 50, right? Yeah, less than 50. Here it is a mild case, and because of that, it is 53, right? It is 53. Right, doctors? But this is kind of not mild, right? This is like a moderate case. Here it's more than here more than 50, that means 68%, right? You can see the like it's like enlarged, right? Heart is enlarged, right? Okay, now you can think about this also kind of same like pericardial effusion. What is the difference? Pericardial effusion has the unique shape, right? Unique shape. But here it's not like that, right? Here, this is not like the water bottle, right? But in pericardial effusion, there is a unique shape, right, doctors? Okay, yeah. Now, what else we have? Mm-hmm. 1 minute. Okay, so yeah, I'll show. Yeah, now tell me how aortic dissection present. I'm just discussing only like main features. Okay, yeah, main features only. So tell me, doctors, how aortic dissection present, because this topic is asked in November. Yes, widen mediastinum, right? Okay, we'll do this question. Okay, I have done this question before my exam. You can see it's 11th November, right? I got it from my notes. Okay, let's discuss. This question came in the exam. Not exact one, like same kind of question, okay? Because they have given the chest X-ray of the aortic dissection. A 55-year-old man present to the image. Doctors, can you mute to? Okay, so a 55-year-old man present to the emergency department with 3-hour history of sudden onset and sharp chest pain. He feels sweaty and has difficulty breathing. His medical history includes hypertension, for which he is currently taking perindopril and atorvastatin. On examination, he looks unwell with a blood pressure 100 by 75. Pulse is 105. Temperature 36.5. Respiratory rate is 20. Then, SaO2 99%. Then soft diastolic murmur at the rest of chest murmur and the rest of chest examination is unremarkable. Then ECG shows sinus tachycardia, chest X-ray performed. So what you can see in here? What you can see in here, doctors? Tell me what you can see in here. Yes, widened mediastinum right here. The chest X-ray demonstrate the widened mediastinum in combination with chest pain indicate likely diagnosis of aortic dissection. Risk factors for aortic dissection include inherited diseases sorry, such as Marfan syndrome, Ehlers-Danlos type 4, hypertension, previous surgery, infections, and increase in age. Like if you have not good knowledge about these genetic diseases, I have uploaded all my notes in that my drive link. Okay, so you can go and check it. Doctor's aortic dissection management and everything. It's a huge topic, right? Yeah, that's right. In the beginning, I told you today we are not discussing about management, right? Yeah. Okay, let's see if we have time. We will discuss. Okay, because today also we have discussed so much. Yeah, doctor. It's in the main group, our group, and every group I have shared my drive link, because some notes are included in this drive link, and other notes I have shared with the as a files, right? Yeah. So you have to check both of them. So let's discuss. And hypertension, previous surgery, infection, increasing in the pain is described as sudden, severe, and tearing and may radiate to the back or abdomen. It can also mimic the pain of acute myocardial infarction. The diastolic murmur present is indicative of aortic regurgitation, which can occur with aortic dissection. Based on the Stanford classification, type A involve the ascending aorta and type B involve the aorta beyond the left subclavian artery. Doctor, like if you want to get an idea about the aortic dissection, I'll share the I'll share the link, okay? Because we have discussed this aortic dissection topic, then you can like quickly go through it. Otherwise, because when we have discussed before, we have discussed in the this top management, you should know about the classification, right? And what is happening, right? Like according to that, only we have to decide the treatment. So don't worry, I will share the link again. I think it's in YouTube, aortic dissection topic. I think it's in YouTube. Don't worry, I will share the link. Then other doctors can have a look, right? Yeah. Okay, so that's all for this chest X-rays. Like if you have any other things that we can add to this chart, because these are like high parts, not everything. Okay, not everything for chest X-ray. If you have something else in your mind, just add here. Then I can explain that as well, like other diseases or something that can present in this chest X-ray part. We'll move to the next part. We'll move right. Okay, because these are the like main points that you should know about these things, and other than that you should know about the treatment each case, especially hemothorax. Please, in every month we have discussed, I think 5 months of recalls back. In each month they have asked from this hemothorax, and if you have no idea about hemothorax treatment, please do all the hemothorax emergency question. Then you can make your algorithm. Like first what you should do, then next what you should do, like that. Okay, because very high yield, and you should know each step. Like when you should go with this, when you should go with this, like that. Okay, right. Okay, so we'll move to. Okay. Okay, here also we are not discussing about treatment. We are just have a look uh, on the pictures. Then you will identify. Other than that, I will ask some small questions. Okay. Okay. So now tell me, what types of melanoma do you know? What types of melanoma do you know? What types of melanoma do you know? Yes, we have nodular melanoma. We have superficial melanoma. We have lentigo melanoma. Right. What else? We have acral melanoma here. We have acral melanoma, we have lentigo melanoma, we have superficial melanoma, and superficial melanoma is the most commonest one, right? And we have nodular melanoma, and we have amelanotic melanoma as well, right? Amelanotic. The color is not like usually the melanoma color is darker, right? But in amelanotic melanoma, it's present as the pink, red, or flesh colored, right? They are usually harder to tell apart from other skin conditions. As a result of amelanotic melanoma is usually diagnosed later compared to other types. And this is a not very commonest one. Yeah. Now tell me, like, please do, I think, 9 questions in this lentigo melanoma in e-medicine. Do all these 9 questions for lentigo melanoma. You can just search in it as lentigo melanoma, because like in different questions you can collect some key points, right? Because some cases, because lentigo melanoma is melanoma in situ, right? Very benign case. In some cases we do not need to do the excision, right? In very not in every cases, very rare cases, we can just observe it, right? We can just observe it, and we can do the follow up. So you should know each points, right? Because of that I'm telling, please do that all 9 lentigo question, because lentigo melanoma is one of hot topic in November exam, and they have asked in February exam as well, right? And here this exam also they can ask, because this lentigo melanoma is a very famous topic for AMC so far, right? So please go and check. And we have mucosal melanoma and acral lentigo melanoma here as well. And another one, the what? Melanoma in eyes, right? Yeah, ophthalmic melanoma. So usually if you see this ophthalmic one, yeah, or ocular one, or melanoma in eyes, so what you should do, doctors? You have to do what? Tell me what you should do. Yeah, you should refer this patient, right? Because they are ocular melanoma. I got the question in November exam as well. So answer was some refer to, I think, ophthalmologist or can't remember something. I think ocular surgeon or ophthalmologist or ocular surgeon. I can't remember properly. Something refer. Okay, if you see any ocular melanoma, so always go with refer, right? We are not going to do the biopsy or excisions here. It should be done by the specialist doctor, right? Yeah, please remember. Now, basal cell carcinoma. Basal cell carcinoma also, you should know. Yes, eyelid as well. Yeah, yeah, doc. Mm-hmm. Like most of the cases that related to eye, we have to refer, right? Mm. And sometimes they can give it 1 minute. I think I have just 1 minute. I'll show some pictures. Then other doctors also can get an idea, right? Because this is a very hot, very good topic. AMC's hot topic. 1 minute. I have added everything in our February call file. Okay, Dave. One minute, doctors. I had to find it out. Just find out. Notice in the chat. Hmm. Okay, so we'll do some questions. Okay, you should know about the punch biopsy. Okay, like this kind of lentigomelanoma. So what we should do? We should do in here. What we should do in this kind of melanoma, doctors? I'm not reading the question. What we should do? Tell me what we should do. What we should do? Mm-hmm. Yeah, here. Here. Okay. If I'm going to discuss about this, I have to discuss from the beginning, right? Because there are so many things. Yeah. Here, doctors, you should remember. Okay, we'll do some questions. 35 years old man present to the GP clinic with painless facial lesion that has been slowly enlarging over past 10 years. He denies any itching, bleeding, or ulceration or lesions. He works as a farmer and has significant sun exposure. He has no significant medical history and take no regular medications. On examination, appear well with vital signs within normal limits. And there is asymmetrical pigmented follicular opening and rhomboid structure. So in that case, what we should do, we have to do the partial biopsy. Why? Why we are going with partial biopsy? Anyway, if we saw something like melanoma, we have to do the first thing first biopsy, right? First thing first, we have to do the biopsy. But in like these cases, like this much large lesions, we can't excise everything here, right? To do the histopathology, right? To do the histopathology. So because of that, we have to use partial biopsy. Under partial biopsy, we have different types of partial biopsies, right? We have punch biopsies, incisional biopsies, and shave biopsies and frozen section biopsies, right? Frozen section biopsies. In this case, better to do the partial biopsies. Why? Because the facial location and likely large of the lesion, this can be performed via punch, incisional, or shave technique targeting the most suspicious area. Multiple map biopsies may help to define the extent of the lesion. The approach allows the histological diagnosis. Okay. First of all, you tell me if you see a melanoma suspicious, some lesion that you are suspicious of melanoma, then first what you should do? First, what you should do, I'm asking stepwise. First, what you should do, doctors? First, what you should do? Yeah, first you have to do the biopsy, right? First you have to do the biopsy. Why? You have to do the initial excision. If you saw something suspicious of melanoma, you have to do the initial excision, exclude or confirm the diagnosis of melanoma, because we need some biopsy, right? We need to confirm from the histopathological investigation, right? Because of that, we have to do the initial excision with 2 millimeter lateral margin. Where's 2 millimeter lateral margin, doctors? Yeah, you have to mention it, right? Initial one is initial excision with 2 millimeter lateral margin, right? After that. And here they have mentioned something. Partial biopsy by punch, shave, or incision is not usually recommended, but it is associated with false negativity. But partial biopsy should only be performed if complete excision is too difficult, right? Like example in previous face picture, right? Because that area is very hard to do the complete excision as an initial one to take the histopathology. So in that case, you are using partial biopsy. Right, then okay, then after confirming the melanoma by the histopathological finding, then next what you should do, doctors? Next what you should do? Next, yeah, you have to do, wait, what is, yeah, you have to do, doctors, what you have to do? What? Wide excision. This is the treatment, right? This is the treatment. The initial excision with 2 millimeter lateral margin, this is the investigation. Initial excision is the investigation. Sometimes we can, like if it is a very small one, we can just remove everything with this initial excision, right? Like be practical, right? Initial excision. But the function, the goal of doing this initial excision with 2 millimeter lateral margin, why? To investigate it. This is a melanoma or not, right? We need to send sample for the laboratory, right, to get an idea about histopathology, right? After confirming it is as the melanoma, then you have to do the here wide local excision. Wide local excision, because this is the treatment. It should be done ideally within 4 weeks. The definitive treatment is what wide local excision. It should be done within 4 weeks, right? And this excision, this wide local excision is depending on the what? Depending on the thickness of the melanoma, right? Thickness of the melanoma. If melanoma in situ, we have to do the excision, this wide local excision, up to 5 to 10 millimeter. If it is melanoma is thinner than 1 millimeter, 1 centimeter excision. 1 to 4 millimeter thickness, 1 to 2 centimeter excision. Thicker than 4 millimeter, 2 centimeter excision, right? Please remember these are very high yield, doctors, okay? Yes, yes. Good, doctors. After break. Yes, yes, good. Yeah, yeah, burst low thickness. Yeah, that's correct. Please remember these things, okay? And you should know about. And another thing you should know about the melanoma, these warning signs. So, what are those warning signs, doctors? Yeah, AMC is like favorite topic melanoma. So, what are the warning signs? These are very important because from this part we have to decide the treatment. Yeah, if here, if melanoma warning signs mean consider melanoma when lesion is usually this uh, we can use this criteria when we decide in the treatment for lentigo melanoma. Why? Because lentigo melanoma is a melanoma in situ, right? It's a benign case. And it is a benign case, and if this benign case has new or change in most melanoma arise de novo rather than from pre-excited mole. If this is new or changing, if this melanoma, this lesion is new or changing, or this is prominent and pigmented and standard out from other moles like ugly duckling, or rapidly growing, or particular concern to the patient. Particular concern mean if it is starting to itching, right? It make the some discomfort to patient, right? Like that, okay? Or ulcerating, right? Those are the particular concern to the patient. Or atypical on the dermoscopy, like asymmetrical pigmentation, blue white veil, multiple brown dots, pseudopods, radical streaming, change on segmental dermoscopy. So if these are present, that mean it is becoming malignant, right? It is becoming malignant, then you have to do the definitive treatment as the excision, right? Okay, I'll show some question. Okay, not this one. Okay, here. So let's do this question. I think this. Mm, okay, we'll do these questions as well. 89-year-old man attended to the clinic for advice about a lesion on his face. This has been present for about 8 years, has not shown any obvious changes, and does not bother him. But the patient's son said he get it to see. So patient had a small MI 2 months ago and is currently on dual antiplatelet therapy. Which one of the following is appropriate plan of management? Review in 6 months, ibuprofen topical cream, topical liquid nitrogen, excision biopsy with 2 millimeter margin, excised with 5 to 10 millimeter margin. So what do you think? Okay, here doctors, please remember this example is lentigo melanoma or Hutchinson melanotic freckle. It is characteristically found on the face of elderly patients who have had excessive sun exposure and will have been present for many years. It is a subtype of melanoma in situ. Unlike other subtypes of melanoma, it can remain indolent for several years before progressing into an invasive melanoma. The risk of invasive transformation is reported to range 2 to 5. Hence, a younger patient or in elderly patient who are otherwise fit and healthy, the current recommendation is to have the lesion surgically biopsied with 2 millimeter margin depending on the result. This may be followed by complete wide excision with 5 to 10 millimeter margin. However, in this case, the lesion has remained unchanged for many years and the patient is elderly and would be quite reasonable to keep it under close review, particularly as the patient does not appear to be bothered about it. In addition to the patient currently on dual antiplatelet therapy, and any decision of surgical excision should be deferred until a few more months have elapsed. A careful discussion has to be done with the patient and his family with a careful documentation. Yes. Okay, Doctor. Yes, Doctor Vajra. Yeah, Grace. Yeah. You have marked it correctly. You remember the question, right? Because I have explained this question and everything in our recall class very well because they can be tricked by this kind of question here. Like, can you see any of these warning sign in this case, doctors? Can you see any of warning signs here? Here, this lesion stay for 8 years and no obvious change or does not bother to him. But because of patient's sons, only he want to do the what he want to do the examination, right? So because of that, there's no need of do the excision. But I'll show another question. Okay. Okay, this one. 75-year-old man present to the his GP clinic with a lesion on the right side of his nose. This has been present for about 7 years and has recently noticed that it appears to be increasing size. So there's a warning sign, right? We can't keep it like that. We have to do something, right? Because it is becoming malignant, right? And so, what we should do, doctors, here, which one of the following is most appropriate initial management? Mm-hmm. Yeah, here we have to refer for the excision, right, doctors? Here, options provided refer for the excision is therefore the most appropriate, right? Hope you understand, right? Like I have attached here the three types of question they can ask. Here, one type. Here, it's becoming malignant, right? Because of the increasing size. And in the image, there are some question, and they have just mentioned in like this lesion stay for like 7 or 8 years. Now it's becoming itchy. And it is not comfortable for the patient. Itchiness also a malignant feature, right? Malignant feature. So please keep those things in your mind. These are very important. Yeah, yeah, Dr. Arun. I think we have discussed so many times, right? Now in your mind you can see the picture and now you can tell the answer, right? From your memory. Right? Yeah. Please, melanoma, save us. Yes, yes. Yeah, yeah. Just do that, those 9 questions. Believe me, there's no problem after doing those lentigo melanoma 9 questions. Okay, so I'm only talking about lentigo melanoma. Okay, yeah. So yeah, that's all. This is the three main scenario that here you can see how many questions they have asked in melanoma, like very weird questions here. These are melanoma questions. Okay, here melanoma question they have asked in not just melanoma, lentigo melanoma questions. Okay, so because of that, it's a very high yield topic. So never forget it. Okay, so we'll not take. So now tell me about basal cell carcinoma, how it appear. Basal cell carcinoma, how it present. Tell me, doctors. Okay, pearly. Mm-hmm. Telangiectasis, you can see. Okay. Sun exposed area. Yeah. Mm-hmm. Good. Roll, foliage, telangiectasia, central. Okay. Yeah. Yeah. Here you can see a typical picture. Yeah. Rolled edge, pearly shape, central telangiectasis, right? Yes. Yeah. Good. Okay. So here and there are different, that is a typical presentation, and other than that you have different types here. Superficial BCC here, and here you have what nodular BCC, and you have ulcerated nodular BCC, right? These are from therapeutic guideline, okay, but they are not very good images. not very good images. And here you can see the infiltrative morphoid BCC. Just for your reference, I have added. We'll do some questions, then you will understand. 68-year-old woman present to the GP clinic with lesion on her nose that has been slowly growing over the past 8 months. She worked as a retired gardener and has a history of extensive sun exposure. She has a medical history of hypertension and osteoarthritis, for which she takes amlodipine and paracetamol. On examination, she appears well with vital signs within normal limits. There is a 1 centimeter pearly nodule with surface telling the ectasia on the left lateral aspect of the nose here. You can see, right? The lesion is non-tender and does not bleed. They are asking what is most likely to diagnose. So you all know pearly nodule with surface telangiectasis. That mean you can it's a BCC, right? Yeah, and doctor's good. Okay, here also I have attached. So here they have given good images for other things as well. Here this patient presentation with classical features of BCC. This is most common skin cancer, typically presenting as a slow growing pearly nodule with telangiectasias vessel. So rolled edge and ulceration is also commonly seen. The nose is one of the most common sites due to the chronic sun exposure. The patient's history as a gardener with extensive sun exposure is a significant risk factor. So, how is squamous cell carcinoma present? Typically present as firm, scaly, crusted plaque or nodule that may be ulcerate, and it tend to grow more rapidly than BCC and often has a rougher, more keratotic surface, right? Here, this is Bowman's disease, I think. Squamous cell. This is image one. Mm, okay. This is melanoma, and this is dermatofibroma. Okay, yeah, this is the squamous cell carcinoma, right? Ulcerated case. They have mentioned. Okay, don't worry, I have added it. Yeah, this is the melanoma. Yeah, we'll do the next question because we will discuss all the other parts, squamous cell carcinoma and other things later. Okay. So 78-year-old man presented to the GP clinic with lesion on the back of his right ear. That is that his wife noticed several months ago while trimming his hair. Right. Then she thinks it. Okay. She thinks it has been slowly growing in size. The lesion is painless and does not bother the patient, but his wife insistent to see the doctor. The patient is a retired farmer and he has no significant medical history and does not take any regular medications. On examination, he appears well with pulse rate 72 and BP 128 by 76, and the lesion on his right ear is shown here. So, which one of the following is most likely to diagnose it? So, what do you think, doctors? What do you think? What do you think? They have given squamous cell carcinoma, BCC, amyloidic melanoma. Okay, now tell me, why this is BCC? What you can see in this picture? Okay, rolled edge. Okay, yeah, pearly shape, telling the excess. Let's see. Here, this image depicts classic BCC. The most common type of skin cancer. BCC are usually slow growing, painless lesion that typically occurs in sun exposed area. The characteristically have the pearly white rolled edge with central ulceration as seen in here. While BCC have a very low risk of, I have not added other parts just to get an idea, right? You can see Telangiectasis in middle, right? And rolled edge, right? Yeah. And pearly shape, right? Yeah, like that. So here also a good example you all can see. Okay, should I ask the what is the treatment? It's not very long one. Tell me the treatment of BCC. How we divide treatment? Okay, here. Okay, we'll do this question. Then you will answer. Okay. 65-year-old man present to the GP clinic with a skin lesion on his left nose labial fold that has been present for several months and slow growing in size. He reports occasional bleeding from the lesion. His medical history include hypertension and hypercholesterolemia, for which he takes regular medications. He's a non-smoker and works as an engineer on construction site with significant sun exposure. On examination, he appears well with vital signs within normal limits. The lesion image documented an inferior aspect of the left nasolabial fold. This is the image. Which one of the following is most appropriate treatment? So, what do you think? A, B, C, O, D, O, E. Mhm. Here. So, yeah, answer is surgical excision. The patient present with nodular basal cell carcinoma in cosmetically sensitive area. The clinical features of pearly appearance with telangiectasia is a classic for nodular BCC. So, surgical excision is most appropriate treatment. Now, like if we discuss about generally the treatment, how it depend on doctors. We have superficial one and what else? Good, good. Mm-hmm. Yeah. So, what is the treatment for superficial BCC? Superficial BCC. Mm-hmm. Yes, good. So, now tell me the treatment of superficial BCC. Imiquimod, good. Here, what we can use? 1 minute. So usually we can use imiquimod 5% cream topically, or there can be a liquid nitrogen therapy as well, right? Other than superficial BCC, we should do the surgical excision with margin. How long margin should be? 3 to 4 here. 3 to 4 millimeters typically recommended, right? Please remember these things, right? Now tell me when we should use the refer option in BCC. Okay, you can think about refer for sorry, this Mohu micrographic surgery. Tell me like examples. Okay, patient with multiple comorbidities. Good. Because in therapeutic guideline, there is a three criteria for referral, right? So first one is the patient is elderly or has multiple comorbidities, right? Second one, excision is required but likely to result in significant morbidity, like what around in eyes, nose, or lips, right? Third one is excision is required but contraindicated. In these three cases, we have to refer this patient, right? Refer this patient. Okay. Usually, we can refer this patient to do this micrographic surgery, right? For what infiltrative, morphoid, or micronodular type, poorly defined. Like there are another indication for this micrographic surgery. Usually, they are asking those refer three things, right? Three criteria that they have given in therapeutic guideline, right? Mm-hmm. And other than this excision, for If this BCC is very aggressive, and after excision, what we can do, doctors? Mm-hmm. Yeah, usually we can do the radiotherapy as well as the adjuvant therapy after excision. For what? For aggressive BCCs, right? Aggressive BCCs. Please remember this part as well. Yeah, that's all for BCC. Now tell me how squamous cell carcinoma is present. How squamous cell carcinoma is present? Okay, tell me, what is the name of squamous cell carcinoma in situ? Give me example. Squamous cell carcinoma in situ. What is it? Bowen's disease, right? So Bowen's disease. Then we have invasive squamous cell carcinoma, right? Mhm. Okay. So now tell me the yeah, typical squamous cell carcinoma, how present? How it present? Typical squamous cell carcinoma. Sorry, just give me 1 minute. Yeah, sorry, doctors. Yeah, I got some sneezing session. Okay, so how it present? Yeah, it's a erythematous scaly patches, well demarcated, slow growing. Is it slow growing, doctors? Or is it slow growing? So, this squamous cell carcinoma in situ is slow growing, right? This Bowen disease, right? Otherwise, it is not slow growing, right? Yeah. Yeah, it's fast growing, right? Yeah. Most commonly see in sun exposed areas, right? Yeah. Sun exposed areas. Good. Good. Okay, we'll do some questions. 72-year-old man present to the GP clinic with 3 month history of growing lesion on his right ear. He works as a farmer and has extensive sun exposure throughout his life, and he has no significant medical history and take no regular medications. On examination, he appears well with vital signs within normal limits, and there is a irregular firm erythematous 2 centimeter lesion with central ulceration and scaling on the right helix. Here you can see. They are asking which one of the following is most likely to diagnosis. Tell me. Mhm. So here, the patient's presentation with typical of cutaneous malignancy on a sun-exposed area, squamous cell carcinoma, typically present as firm, scaly, or crusted lesion that may ulcerate, right? The irregular borders, scaling, and ulceration in an elderly patient with significant sun exposure history strongly suggest the diagnosis, right? Mm, right, yeah. Okay, another one. A 33-year-old man present to the GP clinic with 6 months history of painless growing lesion on his lower lip, and he has no significant medical history and take no regular medications. He works as a retired farmer and spent significant time outdoors. On examination, he appears well with vital signs within normal limits. There is a firm, irregular, ulcerated lesion on the vermilion border of his lower lip here. Which one? They're asking which one of the most likely to cause. Which one of the following is most likely to the causative agent? So we all know this is very associated with sun exposure. So remember this one
Okay.
as well. Doctors, please keep your mic muted, okay? Yeah, remember. And this is the Bowen's disease here. This is the Bowen's disease. So you all can see Bowen's disease. And yeah, then what else? So what do you know about keratoacanthoma? What do you know about keratoacanthoma? What doctor has shared? One interesting things I found in e-medicine for SCC. For initial, we always choose regional lymph nodes. Doctor, can you share this question? Then other doctors also can have a look, right? Dr. Rashif, please, can you share the question? Mm-hmm. Okay. Mm-hmm. Yeah. Yeah. Thank you so much, doctor. So then we will discuss about that one. So what do you know about keratoacanthoma? Keratoacanthoma is a common rapid growing locally destructive skin tumor, right? Right? May regress spontaneously with scarring, but clinically they may be indistinguishable from well differentiated squamous cell carcinoma, and the clinical cause may be unpredictable. So, here we can see the keratic plug, right? Keratic plug we can see in here in this keratoacanthoma, right, doctors? Yeah. And this is a dome shape, right? Dome shape. And we have this keratic plug, right? We have this keratic plug. Okay. So what is the treatment? What is the treatment for keratoacanthoma? What is the treatment for keratoacanthoma? Doctors, what is the treatment for keratoacanthoma? Complete surgical excision, right? Complete surgical excision. I think there's two or three questions in e-medicine. It will take time. I'll show some more pictures. It's from my notes. I think I have shared my notes as well in SCC and BCC because these e-medicine questions can be seen, right? Can be seen in exam because we have witnessed those. The same exact question in exam. Okay, that's why I'm telling this e-medicine dermatological questions are very high. Just 1 minute, I'm just adding those pictures. Okay, just added it. Here, here, this is how you can see the keratoacanthoma with the keratic plug. Okay, here. And here also, this also picture. These are emergency questions, doctors. Okay. So please keep those pictures in your mind. I'll share this PDF. Don't worry. Okay. Now tell me because you need a quick PDF, right, to go through these images. So now tell me, what is actinic keratosis? I have explained these things in our theory class very well. Tell me, actinic keratosis, what is it? Or what is the another name for actinic keratosis? Okay, so yeah, before actinic keratosis, we'll do this question, right? Thank you, Dr. Ashif. Okay, we'll do this question. Okay, this question I remember. Okay, this is 80-year-old man present with the general clinic with 2 months history of bleeding lesion on his right lower leg. He has no significant medical history and take no regular medications. He lives independently and previously worked as a farmer for 40 years. On examination, he appears well with vital signs within normal limits. There is a 1.5 erythematous indurated and ulcerated lesion on the lateral aspect of his right lower leg. So, which one of this is the image, which one of the following is most appropriate next step? What do you think, doctors? What do you think? Mm-hmm. Yeah. So here why. The patient present with suspicious lesion that has features consistent with cutaneous squamous cell carcinoma, including ulceration, induration, and bleeding, right? Given the location and presentation, the systemic approach to assessment is crucial. The clinical examination of regional lymph nodes is the most appropriate next step. For lesion on the leg, this involves examination of popliteal and inguinal lymph node basic. Lymphatic spread is the most common route of metastasis for cutaneous SCC, and clinical examination can identify early spread that would alter the management, right? In this case, so this is the lesion in lower leg, right? Lower leg. And so they have mentioned the lymphatic spread is most common route of metastasis of cutaneous SCC, right? Because of that, we have to do the clinical examination of regional lymph nodes, right? Yeah. I have picked A. If I go with A, yes, yeah. Okay, so here answer is okay, why not biopsy of the skin lesion? Here, biopsy of the skin lesion would typically follow a lymph node assessment while histological confirmation is necessary. The regional lymph node status is more critical for determining the extended disease and planning the appropriate management. Yeah, yeah. Yeah, doctor, and remember about the place as well, right? Yeah, this is in the leg, and here the lymphatic drainage is most common routine here for the metastasis, right? Because of that, they are usually they are doing the clinical examination of regional lymph node. Then after we can do the biopsy and we can confirm it, right? Here they have mentioned typically follows the lymph node assessment, right? Biopsy of the skin lesion, while histological confirmation is necessary, right? Yeah. Yeah. Here, clinical examination of regional lymph node is essential in assessment of cutaneous squamous cell carcinoma. High-risk features of cutaneous SCC include location on lower limb. Yeah, these are the high-risk features if it is located in lower limb and size more than 2 centimeter, and if poorly differentiate and depth more than 6 millimeter. And here imaging is only indicated for high SCC when lymphadenopathy detected on clinical examination. That's a good question, doctors. Thank you so much for sharing. Okay. Yeah. 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 Okay. Okay. Sure. Let's see another question. Okay, doctor, this is not a hard question, right? This is melanoma question. Why? What is the problem? Yeah, because melanoma, okay, let's say it's fine. 74-year-old man referred for the plastic surgery clinic with marked on his face, which has started to itch recently. Okay, the mark has been present for many years and not started to bother him until the itching occurred. The other was in good health. So, which one of the following is most appropriate next step in management? Yeah, type your answers. Mhm. Yeah, here. Yeah, you are correct, doctors. So why here also? What is the problem? I know the your problem is why 1 to 3 millimeter, right? That's the problem, right, doctors? Right? I think because of that you have shared this question because we usually know 1 to 2 lateral margins, right? 1 to 2 lateral margins, right? Yeah, in here, even though like 1 to 3 millimeter margin, we have to go with that, right? Because that is the best answer in here, right, doctors? Yeah. Yeah, because it is not enough. So because of yeah, we have to go with 1 to 3 millimeter margin. Yeah, doctor, in this area we can do it's not in the like not near the cheek, right? In this area we can go. And here this is also converted to melanotic sorry, converted to malignant. Why? The itching has in there is a new symptoms itching, right? Recently itching has in occurred, so we have to excise this one. Okay, your problem is okay, okay, let's see. I think your problem is why not shave or punch or right. Okay, let's see why not punch. An argument could be made for a punch biopsy to establish a diagnosis. However, punch biopsy does not represent the entire lesion, hence it may be lead to incorrect diagnosis, underestimated burst law thickness, not shave might acceptable when the index of suspicious of malignancy change is low, but that is not in this case where the highly chance of malignancy, right? Because in this case we can do, right? We can do the excisional biopsy. It's practical, right? Practically we can do in here. When it is on the top of the ear, do we also no, we have to refer this doctors. We have to refer this patient if it is in ear or eyes like that. We have to refer this patient. Okay, refer for what? Excision. In some cases like they are giving refer for excision, we have done this question, right? So in that case better to go with refer. Yeah, we will take a small break, doctors, right? And yeah, it's 7:51. Yeah, we'll take a small break. Oh my God, we have discussed like 2 hours. We 6, 7. Yes, we have almost discussed 2 hours, right? Oh my God. I didn't even feel that it was a two. I was thinking it's still 1 hour past. Okay, it's fine. We'll take a, 10-minute break and we'll continue. Don't worry. I will continue. Okay. Okay, so what is actinic keratosis? Actinic keratosis? What is another name for actinic keratosis? What is it, doctors? Yeah, we call it solar keratosis, right? Solar keratosis as well. So, what is this actinic keratosis? Tell me, what do you know about this actinic keratosis? Is this malignant or not? Tell me, is this a malignant or not? Doctors, are you there? Doctors. Hello, are you there? Mm-hmm. They are not cancerous, right? They are not cancerous, right? Yeah. And like what we can see in here, what type of lesions? Like how you identify them? How you identify them? Yeah, doctor, it's a precancerous lesion. How you identify them? You should know, okay, because these topics are high yield topic for AMC. These are hypertrophic pigmented lesions, right? Hypertrophic or atrophic pigmented lesions, right, doctors? Yeah. Usually these are asymptomatic. We can see in sun exposed areas, right? Back of the hand, forearm, face, scalp, right? Scalp usually in bald people. And these lesions are large in size from 2 to 20 millimeters in diameter, right? Yeah. And usually this can be seen as like multiple clusters, right? Here also you can see multiple lesions. Okay, we'll do some questions. Don't worry. So, okay, we'll do this question, then you will identify how it appear in the exam. An 82-year-old man presented to the GP clinic for review of his disease, sorry, diabetics. During the consultation, he mentioned some painless scaly lesion on the back of his hand that have been present for many months. He has a history of type 2 diabetes and hypertension. His medications include metformin and perindopril. He worked as a farmer for 40 years before retiring. On examination, he appears well with vital signs within normal limits. Multiple erythematous scaly patches are visible on dorsum of both hands, with one lesion showing signs of ulceration. Here, so they ask in which one of the most appropriate topical management. So before that, tell me what is this? What is this, doctors? Before that, tell me what is this? What happened to other doctors? Mm-hmm. Yeah, these are solar keratosis or actinic keratosis. So now tell me what is the treatment? Tell me the treatment as well. Tell me the treatment as well. Mm-hmm. No, no, you can't be forget this one. Okay, this is a very high yield part. Okay, now it's fine. Now you can remember it, right, Dr. Rehan? Yeah, don't worry. The patient present with clinical features of consistent with actinic keratosis, scaly erythematous patches on sun-exposed area. His history of outdoor work and advanced age are significant risk factors. The presence of an ulcerated lesion raised a concern for possible progression of squamous cell carcinoma. 5-fluorouracil cream is the most appropriate treatment for multiple actinic keratosis, while cryotherapy would be helpful for few lesions. When there are multiple actinic keratosis, it is advisable to consider other treatment due to the pain. 5-fluorouracil works by interfering with DNA synthesis in rapidly dividing cells and particularly effective for treating areas with multiple lesions. Treatment typically continues for 2 to 4 weeks, though local irritation is common, right? Mhm. Actinic keratosis is a pre-malignant lesion that can progress to squamous cell carcinoma if left untreated, right? Because this is a risky case, right? If we are not treating this one, it can be it can be converted to it can be progressed to squamous cell carcinoma. So topical 5-fluorouracil is the effective first-line treatment for multiple actinic keratosis. Regular skin check are most important in elderly patients with sun-damaged skin, right? Yeah. Okay. And what is the other treatment like fluorouracil? 5%. What is the other treatment that mentioned in therapeutic guideline? We have three types of treatment, right? We have cryotherapy, we have 5% fluorouracil, and we have 5% imiquimod cream as well, right, doctors? But most commonly used fluorouracil cream, right? In the TG also they have clearly mentioned under that fluorouracil cream is the most commonly used topical agent because of its lower cost and comparable efficacy. Remember, okay? Yeah. Yes. So, what do you know about seborrheic keratosis? Seborrheic keratosis. This is another high yield topics because sometimes doctors are confused with this actinic keratosis or solar keratosis with this seborrheic keratosis because in here we call it solar keratosis as well, and here we call it seborrheic keratosis. These two are different two things. Okay, please don't confuse. Yeah, appreciate. Yeah, yeah, Doctor. Dr. Bhagya. Good example. Yeah. Okay. So here what you can see, doctors. Here you what is actually seborrheic keratosis? What is seborrheic keratosis? What are the key features in like when I ask about seborrheic keratosis, what is the key features in your like that directly appear in your mind? First thing, yes. Even I'm still laughing about pressure sultan, right? Yes, benign waxy appearance. No, no, no. This is not melanoma, doctor. Yeah, okay. What you can see? You can see the waxy appearance here, right? This is the image, and you can see this is dermoscopy image. So you can see the waxy appearance here, right? Don't worry. This is the very easiest one. Doctors, have you not watched our skin lesion sessions in YouTube? We have gone through this one and all the images as well, right? So here we can see this waxy appearance, right? So what are the key points? I'll explain here because yeah, I'll explain before that here. Seborrheic keratosis. This is the key points that you should know. Benign epidermal tumors, right? Common on all the adults and stuck on waxy or verrucous appearance, right? Waxy or verrucous appearance, well demarcated. And here, these are asymptomatic. Here, well demarcated brown or black lesions and non malignant potential. Reassurance only unless symptomatic or due to cosmetic reasons. Yeah. Okay, that's be. Yeah, yeah, sure, doctor. You should go through. Those videos are not very long videos. Okay. So here we'll do some questions. Okay, here. It's a very easy, right? You can see the waxy appearance here, right? Here. So this is also a good example here, seborrheic keratosis. The most likely to diagnose in this patient seborrheic keratosis. These are benign epidermal tumors that commonly occur in older adults. They typically appear as well demarcated brown or black lesions with waxy appearance, right? Which matches the description in the case. Sorry, doctors, I have only attached the picture and the this one as well, not the question. But it's fine. We have done this question, right? Yeah. And here, while the duration of the lesion is uncertain due to the patient's cognitive status, the characteristic appearance strongly suggests the seborrheic keratosis. And this is a full black one, right? Here also waxy appearance you can see, right? Here, during the routine assessment, his GP noticed a lesion on 87-year-old man's left upper eyelid. She is told that this has been present for many years and does not bother him. It is painless but has now started to itch. It has had no significant changes in appearance over the years. He has several similar lesions on his back His medical history include hypertension, of which he takes captopril. He is a 20 pack year smoking history he has. So which one of the following is most likely to diagnose? So in this picture, you can see it as a seborrheic keratosis, right, doctors? Yeah. So next one, 75-year-old retired farmer comes for the routine skin check and complained of an increased number of raised wart-like lesions. Here, raised wart-like lesions on his back. He has noticed them appearing over the past 10 years or so. When asked, patient says he has not noticed any pain, itching, or bleeding from these lesions, and they are not changing rapidly over the time. And patient otherwise well. Has a medical history of diverticulitis and GERD. Medications include omeprazole, and he has no history of burns, organ transplant, or immunosuppression. As a farmer, he always wore sun protection, and he has no family history of any type of cancer. He's a non-smoker and drink 2 glasses of wine per week. Here also they are asked to diagnose it. It's a seborrheic keratosis, right? Doctors, please keep these pictures in your mind, right? Seborrheic keratosis here. Waxy like appearance, right? Yeah, here. Mm-hmm. So not very hard one, easier one, right? Okay, and in the November exam, they have asked this one. This image was given to ask diagnosis, right? Ask diagnosis. So, what do you know about pemphigus foliaceus? What do you know about that? What do you know about that disease? What is that, doctors? This is the November exam question. Because of that, I have added this part as it. Okay, autoimmune. What else? Okay, let's discuss here. Pemphigus foliaceus, autoimmune blistering skin disease, right? Autoimmune blistering skin disease, antibodies against desmoglein 1, and superficial fragile blisters that rupture easily. Because it's an autoimmune blistering disease, right? Here, then crusted scaly erosions can be seen, no mucosal involvement, and here Nikolsky sign is positive, right? Then here treated with systemic corticosteroid with or without immunosuppressant. Why? Because this is a autoimmune disease, right? I'll show another picture here. Also, you can see, just keep these pictures in your mind as well. Okay, this is from Dermanate, Pemphigus foliaceus, right? And in this question, I think they have given the proper question, right? Just not the picture only. They will give the erosions and everything, okay? And the blisters and they ruptured everything. And you should know to differentiate this Pemphigus foliaceus from seborrheic keratosis, because this is seborrheic keratosis in back of the patient, right? Back of the patient, and you can, because this is the picture given from the recolor, right? Recolor, and you can be confused. That's why I have added this picture here. Yeah. Okay. What? Mm-hmm. Yes. Good, doctors, you remember it. Yeah. Then that's why I have added both two in here, and melanoma is something different, we all know. But don't worry, in the STEM they will give a proper question. Actually, we couldn't find a related question in emergency as well, right? Otherwise I could have added it. Okay, so remember. Okay, next topic is atopic dermatitis. How it present atopic dermatitis? Tell me, atopic dermatitis. What is the picture? What we can say? Itchy. Okay. Yeah, we can see itchy, dry, red patches, right? Especially in face, flexures, wrist, and ankles, right? Ankles. And so, what are the aggravating factors? Irritants, right? Sometimes can be soap, wool, infections, other stress, right? Like that. Here, atopic dermatitis present as dry erythematous patches. It can affect any area of the skin, but typically occurs in face, cubital, and popliteal fossa behind the elbow and knees, wrist, and ankle. The hallmark of atopic dermatitis is itchiness, right? So please keep these things in your mind. Atopic dermatitis is the result of complex interplay between genetic and environmental factors. I just read from the therapeutic guideline, okay? And usually, this atopic dermatitis commonly develop in the first year of life, but can present for the first time in adults as well. Okay, and here you have to know about the treatment, right? So, what do you know about treatment, doctors? What do you know about treatment? I'll show those from the e-medicine. Then you will understand. Yes, good. Mhm. First, directly, are we going with corticosteroid, doctors? What we should do? 1 minute. Okay, very important questions. Okay, okay. This is okay. We'll do. 34-year-old man present to the GP practice. GP practice concerned about itchy rash affecting the back of his knees and eyelid. He has had eczema for some times and continuous getting flares regularly. He normally use emollients once per day and betamethasone steroid cream and off on his leg when it flares. He currently works as an engineer and cannot think of any new triggers in his life. He washes with body lotions and generally just uses that on the sales at the supermarket. He has no other significant medical history and take no regular medications. On examination, appear well with vital signs within normal limits. The rash affecting his popliteal fossa is erythematous, excoriated, scalene. There's evidence of mild lichenification. There is a similar scaly erythematous eruption across the both upper eyelid. There's a no signs of infection or infection of either rash. What do you think? Which one of the following correct advice to give these patients? What about other doctors? Good. Here, based on the RAS description, location, and his medical history, most likely to due to eczema, right? Eczema or atopic dermatitis is common condition that caused by dry erythematous patches of extremely itchy skin. Develop management surrounding avoiding trigger and minimizing contact with irritants such as soap, shampoo, pools with chlorine, itchy cloths like wool and dry weather. Soap pre-washes recommended to prevent worsening eczema from chemicals and scent then added for many body washes, right? Yeah. Please remember these things, okay, doctors? Here, the mainstay of treatment for eczema include avoiding trigger emollients and steroid cream. Okay, then steroid cream should not be used indefinitely. They should be used during flares and tapered off appropriately. Soap-free wash should recommended for all patients with atopic dermatitis, right? Atopic dermatitis. Okay, here we'll do other questions as well, just few questions, because I need to get a proper answer from you because there can be confusions. A 3-year-old boy presented to the GP clinic with patients with 2-week history of worsening eczema. Yes, patches of dry. Always check this dry, red, itchy skin. Itchy skin is arms, leg, and torso. Parents report bathing him twice daily with soap to keep him clean. Think this would help to eczema. The body has no other significant medical history and take no regular medications. Immunizations up to date. Examination, he appears well with vital signs within normal limits, and his skin is dry with erythematous patches and excoriation consistent with eczema. So, which one of the following is a most appropriate initial step? So, what do you think, doctors? Let's see. Let's see you are correct or not. Yes, you are correct. Good, doctors. I'm actually feeling good. Okay. Because in the I think in first time you have most of the doctors have gone with this topical corticosteroid, right, as the initial management. Because in my recall class also most of doctors have chose this one, I remember. And please always remember what is first line, what is the things you should do first. Here the most appropriate initial step managing this child schema is advise once daily bathing with emollient application. The parent's current practice bathing a child twice daily with soap is like to exacerbating the eczema by drying out the skin and disrupting its nature barrier function. Reducing bath frequency and apply emollients immediately after bathing are key components of the management. So let's discuss about why not this one. Topical corticosteroid would not be the most appropriate first step. Okay, this is not the first step. While topical corticosteroids are often used in eczema management, they should be reserved for flares up and used judicially, especially in children. In initial focus should be improving skin practice. So initially we have to avoid trigger and keep the skin moist, right? Emollients. So this is the first line management, right, doctors? Yeah. Here, this is the correct approach. Please, if you don't have this question in your notes, just take a screenshot and keep these things in your mind. Okay. Here, correct approach to involve the education, the parent about the proper skin for eczema. Reduce bath frequency at once daily for every other days. Using lukewarm water and avoiding hot water. Using mild fragrance free cleanser instead of soap. Limiting bath time 5 to 10 minutes and patting skin with dry gentle after bathing. Apply an emollient liberally within 3 minutes of bathing to lock in moisture, right? So remember, here emollients are the cornerstone of eczema management and should apply it liberally and frequently. Okay, hope you understand it. Very high yield doctors. Mm. Okay, next one. 25-year-old woman present to the GP practice with 2 months history of itchy rash. She has a history of mild atopic dermatitis since childhood, which has been well controlled with using daily topical moisturizers. She has not needed steroid cream since primary school. She takes no regular medications. Her symptoms began shortly after moving into a new share house with 6 other housemates. She reports increased itchiness and redness on her arm and neck, and she also notes sneezing and itchy eyes on direct questioning. She mentioned her new housemate has 3 cats, but cats have regular care for flares and ticks. Patient thinks she might have noticed similar symptoms when she stayed with her aunt is on the farm as well. So yeah, here she has bilateral conjunctivitis and here erythematous scary patches with excoriation marks on her neck and antebrachial fossa, then conjunctivitis and clear rhinorrhea. Which one of the following most appropriate next step in diagnosis? What do you think? And what are the doctors? Let's see. Okay, let's see. YA. Dr. Abba, very good. YA doctors. Here, Here, this patient present with worsening atopic dermatitis and new onset allergic symptoms temporarily related to the cat exposure. The combination of skin manifestation with respiratory and ocular symptoms strongly suggests pet dander allergy as a trigger. So, a skin prick test is the gold standard for diagnosing specific allergies, including pet dander, and in the presence of rhinitis, asthma, atopic dermatitis, potential food reactions, it is reasonable to perform skin prick test to determine the specific IgE allergy. This is eczema, right, doctors? Right? So, okay, so let's see. Then, because we have to check IgE allergies, and here what we can see in this question due to this pet allergy, right? Okay, then next, let's see why not patch testing is used to diagnose delayed type type 4 hypersensitivity reactions such as contact dermatitis, right? It would be not helpful in diagnose immediate type 1 hypersensitivity reactions to pet dander, right? So, hope you understand it. Hope you understand it, doctors. Here, pet allergies can be exacerbated pre-exciting atopic conditions, including atopic dermatitis. A skin prick test is a gold standard for confirming pet dander allergies, even in patients with atopic dermatitis. So, what you can learn from this question, doctors? What you can learn? Tell me the simple like summary. Tell me, doctors, because these are very high yield topics. So you should know skin prick test used for what? To identify immediate or type 1 hypersensitivity reactions, right? So we all know immediate hypersensitivity reactions mean what? IgE mediated allergies, right? IgE mediated sensitivities, right, doctors? Mm-hmm. Then, so IgE mediated allergies, what are those? Atopic dermatitis, a good example, right? Yeah. And examples that can trigger these IgE-mediated allergies, dust mite, pollens, right? Animal danders, right, doctors? Yeah. Then, then when we use patch test used in delayed hypersensitivity, or we call it type 4 hypersensitivity reaction, right? Yeah. This is for what? Usually in contact dermatitis, right? If patients contact with new cosmetics or new chemicals, creams, or anything, or some metals, right? Nickels or new things like cosmetics, metals, and those kind of things, we have to use this patch test, right? Mhm. So remember, atopic dermatitis is skin prick test. So allergic contact dermatitis is patch test. That is the thing you should collect from this question. Good. Okay, we'll do this question now. And then we will move to next one. A 4 months old baby present to the GP clinic for routine immunization. He has a severe atopic dermatitis requiring daily topical corticosteroid and moisturizer. He recently developed an egg allergy confirmed by skin prick testing. He is exclusively breastfed and growing appropriately. He has no other medical conditions and take no regular medications apart from his skin treatment. His parents inquires that introducing solid food and prevent food allergies. Which one of the following most appropriate next step in management? What do you think, doctors? What do you think? Just guess. Okay, we got A's and D's, right? Okay, most of doctors are going with A. Let's check. Why? Here, infant. Okay. Here, why? The infant has two major risk factors for peanut allergy development: severe atopic dermatitis and confirmed egg allergy. Research has demonstrated that early induction of peanut containing food can prevent peanut allergy in high risk infants. The Australasian Society of Clinical Immunology and Allergy guide for introduction of peanut to infant is severe eczema or severe eczema or food allergy recommended for all infants, including those with severe eczema or exciting food allergy. Peanut should be introduced around 6 months, not before 4 months, and in the first 12 months of life when developmentally ready, right? Yeah. So just keep in mind, not very important, not can be important. We don't know what the AMC is asking, right? That's why I'm telling. Okay, that's all for atopic dermatitis. So what is this? Where's my PDF? Okay, here. Okay, so keep those things in your mind. So what do you know about psoriasis? How it presents psoriasis? How it presents psoriasis, doctors? Tell me about psoriasis. What do you know about psoriasis? What are those? How it present? Okay, silver scaly plaque, scaly patches, well demarcated. Okay, the psoriasis, it's a chronic inflammatory and hyperproliferative condition of skin, right? Characteristic by erythema and scales, right? And it range from few plaques to widespread inflammation with pustules and systemic symptoms, right? So in this plaques, these lesions present as symmetrical, well circumcised salmon pink with loose silvery scale, right? Loose silvery scale. Mm-hmm. Okay, right? Yeah. So what is Auspit sign? What do you know about Auspit sign? Tell me, because in the question they can give about that Auspit sign. What is it? Okay. Mm-hmm. Yeah. Mm-hmm. In psoriasis, when we scraped it, what we can say, small bleeding spots can be appeared, right? So that's why we called it like Auspit sign, right? Auspit sign. It's a classical finding in this psoriasis, right? Please remember. Okay, then psoriasis also we have different types. Trunk and limb psoriasis. Here you can see, right? This pink, salmon pink scale with silver shading, right? Yeah. Okay. Then we have scalp psoriasis, and these different psoriasis has different management. Please go through them, okay? Because we don't have time, doctors, actually now, right? Yeah, we don't have time. So you have the therapeutic guideline, and I know everyone has their own notes for this one. If you don't have, just use my note, okay? I have highlighted these PG notes, and I think they are in my that drive link. So remember scalp psoriasis picture. Keep this in mind, okay? Scalp psoriasis. And this is hyperkeratotic psoriasis of the hand. And here, these are the pustular psoriasis of the hand. Here, you can see these pustules, right? Here, pustular psoriasis. Then, yeah, here also pustular psoriasis. And you have this guttate psoriasis. There's a question, as I remember, in e-medicine as well about this guttate psoriasis. Okay. So it's like a droplet shaped lesions, 2 to 10 millimeter in diameter on trunk and proximal limbs. Okay, it's a different, it's not like that salmon pink plaque psoriasis, right? This is like a small lesions like this. Okay. Okay. Yeah. Then let's discuss about tinea infection. So what do you know about tinea infection? Tinea. How tinea infection present? Tell me about tinea. Okay. Mm-hmm. Yeah. It has what? It has annular, right? Ring-shaped lesion and raised scaly erythematous border. Here you can see ring-shaped lesion with erythematous scaly raised borders, right? And in the center, you can see central clearance, right? Central clearance, right? And this is a itchy case, right? The frequent itchiness can be seen, right, doctors? Yeah, and this is caused by what? From the ringworms, right? Right, doctors? Yeah. So give me the example for, like usually this caused by the dermatophytes, right? And so give me the example, trichophyton, microsporium, right? And epidermophyton, dermophytes, okay? So remember about that. And remember about this lesion, how it present, right? It has a central clearance with a raised erythematous borders, and these are ring-shaped lesion or annular shaped lesion, right? Yeah. And we have different types of tinnias, right? We have tinea corporis. Corporis mean body, right? Mm-hmm. And tinea pedis mean in foot, right? Or we call it athlete foot, right? Then tinea cruris, where in groin area, right? And tinea capitis in head. And tinea unguim in where nails, right? Doctors, yeah. And so usually you have to remember, and sometimes treatment can be changing here as well, right? Changing here because it's also like psoriasis, treatment can be changed from different places. So here, please keep those in mind how it present. Yeah. Here, tinea of hand and nails. Here, it's a leg. And here, tinea capitis, like how it present. Mm-hmm. And here, this is carry on, right? This is carry on. So what is this is carry? What is carry on? What is it, doctors? What is this? This can be can ask in the exam, right? It's a painful these bogey mass on the scalp, right? Why? Due to strong caused by why? Due to this strong immune reaction to these dermatophytes, right? Yeah, this is kind of like abscess. It's a, like a very severe case, right? It's a very painful as well. Mm-hmm. There can be, you can see pus here, right? Pus and it's a crusting, right? Hair loss in this area. So many things can be seen in here. Carry on. Mm-hmm. Yeah. Okay. So yeah, we are not discussing about the treatment here. It can be different, right? I think we have discussed this topic because in the therapeutic guideline also they have mentioned about, right? So in the face, so in the scalp, but you should use like that, okay? But it's not very hard, okay? So go through it. Yeah, because we have to discuss so many things. So what is this pyogenic granuloma? What do you know about pyogenic granuloma? Pyogenic granuloma. Yeah, doctor. The antifungal drug is terbinafil. Yeah, terbinafil is the first line drug. Yeah, you are correct. But in sometimes we have to. There's some different cases like just go through the therapeutic guideline, okay? Because it will take so much time. So how pyogenic granuloma present? What is it, doctors? Pyogenic granuloma. How it present? Yeah, another hot topic of AMC, right? They very like to ask about this. Mm-hmm. Yes, this pyogenic granuloma is benign proliferation of capillary blood vessels on the skin or oral cavity. Mm-hmm. And who get this pyogenic granuloma? Usually, this pyogenic granuloma often occurs in children around 6 years of age and during the teenage and young adult life, right? So, what is the causes of this pyogenic granuloma? It can be due to trauma, right? Hormonal influence, medications, right? Like oral retinoid, right? From the cancer treatment, and it can be due to infections as well. Okay. Yeah, contraceptive use. Yeah, doctor. Hormonal influence mean that contraceptive use, usually in 5% of cases. So, what is the typical features of this one? Here, pyogenic granuloma present as a painless red fleshy nodule. Like you can see, it's a fleshy, painless nodule, typically 5 to 10 millimeter in diameter, that grows rapidly over a few weeks. Yeah, it's a rapid growing over a few weeks, right? The surface is initially smooth but can ulcerate and become crusty or verrucous. Pyogenic granuloma is usually solitary, but multiple nodules and satellite lesions can erupt, right? The most common sites are fingers and face. In emergency also, they have given pyogenic granuloma in face and the fingers, right? Hope you remember. Yeah, yeah, doctor. Easily bleeds when even in minor trauma. Yeah, yeah. Here, yeah. Then pyogenic granuloma easily bleed with minor trauma. Please remember. Yeah, so those are the things you can see. Now tell me what is the treatment. Now tell me what is the treatment, doctors? What is the treatment? Yes, you have to surgically excise it, right? Yeah, surgically excised. Yeah, main treatment is surgical excision, doctor. Yeah, in the I know Dermanate they have mentioned about cautery, but the mainstay of treatment is what surgical excision. Okay, keep remember those things. Okay, what do you know about this pityriasis rosea? What do you know? You should know, like when you heard this pityriasis rosea about in your mind, first thing is what? Herald patch, right? Yes, good. Herald patch. Then Christmas tree appearance rash, right? Yes, good. Remember. Right. So what is this, doctors? Yeah. Pityriasis rosea is a common self-limited inflammatory skin condition true to be caused by viral infection reactivation of this human herpes virus 6 and 7. It mainly affect all the children and young adults, right? The eruption begins with the herald patch and may be mistaken for tinea. Okay, here we'll discuss about this herald patch. The herald patch is a single patch that appears before the generalized rash or pityriasis rosea. It is slightly raised oval salmon pink or red plug 2 to 5 centimeter in diameter with a peripheral scale trail in just inside the edge of the lesion. Here you can see. Here also herald patch. Here also herald patch. Here also herald patch, right? Yeah. So here, secondary rash. So what do you know about the secondary rash after herald patch? Just 1 minute. I have to get the chapter. Okay, what do you know about the secondary rash or Christmas tree rash? What do you know? Here, few days to few weeks later after the appearance of herald patch, after few days or few weeks, keep those things in your mind. Okay, more scaly patches or plaque appears on the chest and back, most appearing from the top to down. Few plaques may also appear on the thighs, arms, and neck, but are uncommon on the face, scalp, palms, or soles. The secondary lesions tend to be smaller than the herald patch. They are also oval in shape with a dry surface and long axis in oval lesions. Here you can see oval lesions, and here we call it as a Christmas tree. Here you can see the distribution. It's like a Christmas tree, right? Like here. That's why we call it Christmas tree rash. Okay, like that. Okay, yeah, you know about non-petritria rosea. Here. Yeah, yeah, this is, you can see properly about this Christmas tree rash, right? Yeah. Okay. So how is scabies present? Scabies. Tell me about scabies, how it present, how scabies present, how it present, doctors. Tell me. What are the key features? Okay. Mm-hmm. Okay, good. Yeah. Mm-hmm. So here, yeah, so here the main symptoms is itchiness, right? Itchiness. It's a generalized itch we can see and occurs in 4 to 6 weeks following initial infection. And this occurs within hours of subsequent reinfection. And this itch is worse at night time. Please remember this part, okay? Because in most of the questions they have given this itchiness is worsening at the night, right? And here may persist for several weeks after the treatment as well. Then what about rash? This is the erythematous papules, right? Erythematous papules and excoriations can be seen. Linear scratch marks, right? Okay, then crusting vesicles, those are the things we can see. So let's see where is this burrows. So what is these burrows, doctors? What are those burrows? These burrows are surfingers thread-like track measuring around 5 to 10 millimeter, right? So we can identify these web spaces in palms, soles, fingers, toes, inner wrist, elbows, umbilical, and in belt line right here. Can you see the thread-like? Here, can you see the thread-like burrows here? Here also you can see. Here also thread-like white burrows you can see, right? Yeah, here and see. Okay, those are the main things you should know about it. And when we were discussing about the theory, I have explained about the crusted scabies as well. Remember that picture as well. Type in the, oh yeah, yeah. Dr. Bagi has mentioned about the um, investigation as well. Yeah, we have to do the but microscopy for the skin scrapes, right? From burrows. Good. Okay. No, I'm not discussing about the treatment and other things. That's your duty, right? Today we are emergency session. Yeah. And thank you so much, Dr. Bhagya has mentioned it, right? Yeah. So what do you know about impetigo? Okay, I'm gonna answer. We will do this question. You should, like I have explained this part. Okay, you should never get the wrong answer today. Okay. Okay, here. So for ear, Old boy presented to the GP clinic with a 2-day history of rash on his face and arms. He is otherwise well. He has no significant medical history and take no regular medications. Okay, his immunizations are up to date. On examination, he appears well with vital signs within normal limits. There are multiple honey-colored crust on over small pustules distributed. Here, honey crusted over small pustules distributed across his face, arm, and trunk. Here, which one of the following is most appropriate treatment? So tell me the answer. Mhm. Okay. So what is the theory here? Theory behind it? Mm-hmm. Okay, yeah. Okay, doctors, please remember you should know about what? You should know about when to use topical treatment like this mipiricine and this oral treatment. Okay, so here the answer is what? Yeah, here the answer is oral cephalexin. Why? This patient present with classic appearance of non-bullous impetigo. Okay, usually for non-bullous impetigo, we are using topical treatment. But in here, okay, non-bullous impetigo characteristic by honey color crust from over small pustules. Impetigo is caused by Staphylococcus aureus and Streptococcus pyogenes. Treatment differs according to the extent of the disease. For patients with limited disease, up to two sores without high risk features. For acute rheumatic fever, the topical mupirocin or hydrogen peroxide is recommended. Here, lympho patient with limited disease up to two sores without high risk features for acute rheumatic fever, right? Topical mupirocin or hydrogen peroxide is recommended. In contrast, oral antibiotic therapy is required for extensive disease more than two sores. And here, you should know about high risk features of acute rheumatic fever. That day also, when I was doing the class, even in my recall class, or even in our free theory session class, right? I have explained exactly the same thing, right? So please keep those things in your mind, okay? According to the number of source, according to the high risk factors for the rheumatic fever, the treatment can be changed, right? Yeah, here. So what are the high risk factors for acute rheumatic fever? Individuals younger than 40, Aboriginal or Torres Strait Islander patient residing in a remote or rural location, a Aboriginal or Torres Strait Islander person or Maori or Pacific person residing on an overcrowded household or one experiencing socioeconomic disadvantage, past history of acute rheumatic fever or rheumatic heart disease, a part of family or household with member who recently had acute rheumatic fever or rheumatic heart disease. So oral cephalexin is most appropriate treatment for the child who has extensive impetigo. Cephalexin is often preferred oral antibiotic in children because it allows less frequent dosing than decloxacillin or flucloxacillin, and liquid formulation has more palatable taste of pediatric patients. Do you remember? Yeah, Dr. Bhagya. Yeah, yeah. Yeah, I saw your answer, but I didn't ask, I know, because after the session you again go and check it. So I didn't have any doubt about it. No, no, doctor. You should not do the same mistake again because you have. Yeah, because you have done these mistakes many times, and please go and check again the impetigo therapeutic part of my recall file. Then you will find this recall, this question and other questions, and just simple, very simple. This very simple points you have to remember, right? So you will never get it wrong, right? Yeah. Fourth time is charmed. Okay. Yeah, yeah. Fifth time is you always get the correct answer. Okay. So keep these questions in your mind. Otherwise, because I know most doctors are going with the wrong answer. That's why I have attached this question, right? Yeah. So you should know about this non-bullous impetigo and bullous impetigo, right? Yeah. Sometimes easy things become an idea. Yeah, doctor. This impetigo topic is not a very hard topic, right? It is a very easier topic, but you should know but these easier topics can be tricked by AMC, right? Yeah. All wrong answers, and Dr. Sithara silence made me understand I'm wrong. I didn't show your answer. Okay, okay. Please. Okay, not now. Yeah, yeah. Yeah, sometimes I have noticed and I'm not asking, right? Because I know you all are used to like correct again, right? Yeah. Okay. So let's little bit discuss about non-bullous impetigo. Most commonly found on the face or extremities, but skin on the any part of the body can be involved, right? Begin with the single erythematous macule, which evolves into pustules or vesicle. Pustules or vesicles ruptures release in serous content, which dries leave in a typical honey-colored crust. Minimal or no surrounding erythema can spread rapidly with satellite lesion due to autoinoculation, and kissing lesions arise when where two skin surfaces are in contact, right? That's why we call it this is a contagious disease, right? Okay, so potentially, typically, otherwise, well, they may experience some itching and regional lymphadenopathy. Okay, this is the typical presentation of non-bullous one, but treatment has changed because this can be here small pustules across the face, arms, and trunks, right? Multiple places, right? Extensive non-bullous one, right? Yeah. Then here, so how these bullous impetigo present usually found on the face, trunk, extremities, buttock, and perianal regions can spread distally due to the autoinoculation and present as quickly appear in superficial or small or large thin fold bulla which tend to spontaneously rupture and ooze yellow fluid leaving on a scaly rim, right? More likely to have systemic symptoms, malaise, fever, and lymphadenopathy. Here you can see the crusted lesion, and this is kind of severe one, right? Yeah. And what do you know about this ecthyma? Because this also can ask this ecthyma. What do you know about that ecthyma? Tell me what do you know about this ecthyma? What is this? Okay, I won't dominate. Okay. Mm-hmm. Yes. Yeah. Ecthyma is what? Please remember, because sometimes there can be a like confusion between this impetigo and ecthyma. Okay, ecthyma is a skin infection characteristic by crusted sores beneath which ulcers from. It is deep from impetigo. As same bacteria causing the infection are involved, ecthyma causes deeper erosions of the skin into the dermis, right? That's the differentiation. Otherwise, the same organisms can cause the disease, but this is a deeper erosions in the dermis, right? Yeah. Streptococcus pyogenes, Staphylococcus aureus are the bacteria responsible for ecthyma, right? Here you can see it can be seen like this, right? So here, what is the signs and symptoms? Uh, Here it's usually begin as a vesicle, smaller blisters or pustules on inflamed area on the skin, a hard crust, soon covers the blisters with difficulty to crust can be removed to reveal the indurated ulcer that may be red, swollen, and oozing with pus. Lesion may stay fixed in size and sometimes resolve spontaneously without treatment, or they may be gradually enlarging to a so 0.5 to 3 centimeter in diameter. They resolve slowly, leaving a scar. Mhm. Then here you have to remember we have to go with what doctors usually we are go with oral antibiotics, right? Oral antibiotics, even though they have mentioned about the topical one, mainly we go with oral antibiotic. I think there's a question in e-medicine, right, doctors, about this ecthyma, and they have taken the most appropriate treatment. Yeah, treatment as this oral fluclox or declox, right? Yeah, yeah, oral antibiotic you have to remember, okay? Because we never know, right? Sometimes they can ask from this one as well, right? Yeah. So then what do you know about erythema multiforme? Erythema multiforme. What do you know about? Give me the clinical presentation of erythema multiforme. How it present, doctors? How it present? Mm-hmm. Target lesion, no? What is the other name we called for this erythema multiforme or multiform? Donut, right? Mm-hmm. Target lesion, no? Donut lesion. Yes. It's actually easy to remember it as a donut lesion, right? Here. Can you see a donut here? Here, okay, you can see, right? Target lesion or donut lesion. Here, erythema multiforme is an immune-mediated, typically self-limiting mucocutaneous condition characteristic by target lesions. The significant mucosal involvement distinguish the erythema multiforme major from multiforme minor. Episode can be isolated, recurrent, or persistent. In most cases, erythema multiforme is precipitated by herpes simplex virus, right? Due to HSV, right? Alternative triggers include infections, medications, vaccinations, and classic target lesions present in concentric rings of colors variation with developed symmetrical and acral distribution with or without mucosal membrane, right? Yeah. Okay, here you can see. There goes out. Good thing I don't like it. Okay. So, yeah. So please remember about HSV infection, right? Infection and these target lesion, right? Target lesion. Yeah. So what do you know about erythema nodosum? Erythema nodosum. Erythema nodosum. Tell me about erythema nodosum. What is it? What is erythema nodosum, doctors? Doctors, what is erythema nodosum? They can be asked, like we have seen, right? They can ask in different cases here. So erythema nodosum, it's what? It is what? And I forget to tell about this erythema multiforme. Is there any symptoms? Is there any symptoms in erythema multiforme? Is there any symptoms in erythema multiforme? There can be mild pain or mild itchiness can be seen, right? Okay. Okay, so we were discussing about erythema nodosum. What is it, doctors? What is it? So what is happening in here, erythema nodosum? Okay, good. You have explained about the associated diseases. Now tell me what is happening. It's a paniculitis, right? Fat layer, here fat tissue, right? Fat tissue inflammation, right? Fat tissue inflammation, right? And this is a painful one, right? Painful, right, doctors? First appearance is redness, right? Then patient can develop these painful itchy nodules, right? Here, erythema nodosum is a type of paniculitis, an inflammatory disorders affecting subcutaneous fat. It present as a tender red nodules on the anterior shins and less commonly affect the thigh. The most common area is anterior shin, right? Yeah. It associated with sarcoidosis, IBD, right? TB. Yeah, good. Yeah, doctor. Mm-hmm. Good. You have mentioned all the important points, right? Yeah. Now tell me about erythema marginatum. Erythema marginatum. Where can we see this erythema marginatum? Where can we see this erythema marginatum? Tell me, doctors. Mm-hmm. We can see in where? We can see in rheumatic fever, right? Specifically rheumatic fever, right? Yeah. Is it a major criteria or minor criteria in rheumatic fever? Tell me, doctors. Mm-hmm. We have minor and major. Tell me. Tell me about is it minor or major? Okay, tell me what are the major criteria of rheumatic fever? Tell me about major criteria of rheumatic fever. Yes, Jones, right? Yeah. J means what? Joints, right? So, which joints are mainly affect? So, you can remember it as Jones, right? The name also Jones criteria. And remember, you can remember these major criteria as also Jones. J means joints, right? So, what we can see here, we can see migratory polyarthritis, right? Migratory polyarthritis, right, doctors? So, here what we can see painful swollen large joints, right? And there can be migrated polyarthritis. In one day, there can be a arthritis in knee. The next day, there can be an ankle, right? It's a migrating part, right? So J. Then O mean O. You can remember it as O carditis, okay? O carditis, yeah, carditis. So that what we can see here, we can see murmurs, right? Murmurs and here rheumatic heart disease can be inflammation of the heart, right? Yeah. Then N mean nodules, right? So we can see subcutaneous nodules, right? Subcutaneous nodule. So what are those small painless nodules, right? Usually in extensive surface of the elbows, knees or spine, right? Yeah. Then another letter is E, right? Jones, Jone. Erythema marginatum, right? So why it is a minor criteria? It's a major criteria, right? Right, doctors, it's a major criteria, erythema marginatum. So please remember, okay, don't forget these things. So erythema marginatum is a major criteria, right? It's a non-itchy pink rash with clear center, right? It's a ring shaped or we call it surfinger shape, right? Yeah. So mostly on trunk and proximal limbs, right? Okay. Then Jones, the last letter is S mean what? Yeah. So Sydenham chorea, right? We can see chorea. Chorea mean involuntary, purposeless movements, right? Yeah. So please remember. Now tell me what is the minor criteria? Minor criteria as well. Tell me. Minor criteria, fever, arthralgia, right? Raised inflammatory markers, ESR, CRP. Then we can see ECG changes, right? ECG changes, prolonged PR intervals, right? Mm-hmm. And here, minor criteria also, remember, you can answer what? FARP, right? FARP. FARP. F mean fever, A mean arthralgia, R mean raised ESR, CRP, P mean prolonged PR interval, right? Yeah, doctor. Please remember. Yes. Yeah. Okay. Remember. Now tell me what is the diagnostic rule? What is the diagnostic rule? Yeah, FARP and Jones. Yes. So now tell me what is the diagnostic rule? How we should confirm it as, how many major and how many minor should be there. Tell me. You can't forget these things. Very high yield, okay? Tell me. Two major O, okay. Two major O, one major, two minor. Plus what? Is there something else that I should add? Okay, is there something just only minor and major criteria are enough? Oh, yes, yes, you should. Yeah, 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 doctor, yeah. You should need to have evidence of streptococcal infection, right? So positive throat culture and this assault, right? What is assault? This assault titer should be elevated, right? Yeah. Yeah, doctor. Please remember, okay? I feel like you have forgot it because the rheumatoid fever is a huge topic and you should remember each points, right? If you have forget it, just go and do the emergency question. That's the only thing. Otherwise, there's no time to go and check the theory. Yeah, just do e-medicine question. Like not everything, just you can select some questions. Like once you are reading the question, you can identify like this is a good question. No, like this is just the same or normal question. So please do that. Okay. Yeah. So erythema marginatum here. This is how it present, right? Ring shaped, and here central pale color. You can see. What else other than that you can see? Is it painful or not? It is not painful and not itchy, right? Yeah. 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 Serpentigious, the pattern, or just you can remember it as ring shaped as well. Okay. Yeah. Yeah. Then, what is snake? Like serpentigious mean what? Snake like, right? Here, snake like. It can be. Yeah. Here, like that. Mm-hmm. And remember, pale center. Mm-hmm. Okay. Yeah. Now tell me, what do you know about urticaria? Urticaria, how it present? Yeah, urticaria. Yeah, urticaria characteristic by very itchy wheel. They are itchy wheels, right? Or we call it hives, right? Hives. With or without surrounding erythematous flares, right? The name of urticaria derived from the common European city Neta Utrica dios. Urticaria can be acute or chronic, spontaneous, so inducible because there is a classification in Dermanate. I don't think you will need that classification. Okay. A wheal is a superficial skin colored or pale skin swelling, usually surrounded by erythema that lasts anything from few minutes to 24 hours. Here you can see. Here you can see wheal raised one. Then what do you know about herpes zoster? What do you know about herpes zoster? What do you know about herpes zoster, doctors? Herpes zoster? Herpes zoster? What do you know? Mm-hmm. Okay, yeah. Here, herpes zoster is localized blistering and painful rash caused by reactivation of varicella zoster virus or herpes zoster, also called as shingles, right? Shingles. So varicella zoster is also called herpes virus 3 and is a member of herpes virida order of double-stranded DNA virus. So here you can see what is this what we call this kind of rash? What we call, doctors? Tell me. Okay. Yeah, this is a dermatiform distribution. So in here, what is the name of the rash in this area? Just 1 minute, I'll show it. That's that rash. Yeah, Huntington. Okay, yeah. 1 minute, I have explained it. 1 minute, I can't find it. Yeah, sorry. Hutchinson something. Hutchinson. Mm, no, doctor, we specifically called this one. I can't find because in my note I have added it. I'll share it. Okay, later. Like in the head, in the area of these dermatomes, we call it Hutchinson sign. It is a ophthalmic shingles characteristic by rash of vesicles on nose and signet. Yeah, I related to eye. Okay, I think this it has mentioned in, yeah, Huntington sign. It has mentioned in therapeutic guideline, doctor, because I can't find it. In therapeutic guideline, it has mentioned. I'll share my note. Don't worry, okay? I can't find how I have shared, like saved it because, yeah. But 1 minute. Okay, okay. Yeah. Yeah, Dr. Arnima, please share it in the March group as well. And other doctors also can be seen. Okay, okay. I found my note. I'll share it. Okay, too. Because sometimes they are giving this hunching sign. Then you should know where to use. Okay, I found my note as well. Okay, doctors, just yeah. Here, this is a Hutchinson sign. Hutchinson sign here. Okay, not here. So here also good picture. Hutchinson sign mean can't zoom it. I don't know why. This skin lesion at the tip of nose indicate the involvement of the nasociliary. Just remember it, okay? You don't need to know like so many things. Make it appear with this nasoaxillary nerve. So Huntington sign. Yeah, here you can see the vesicles eruptions like that. Yeah, yeah. Okay. What else you should? Yeah, and yeah, another one also mentioned. Yeah, okay. So please keep those things in your mind, okay? Because they can give those things. So now tell me, what do you know about acne vulgaris? So what is this acne vulgaris? How it present? Acne vulgaris. Tell me, doctors, what are those acnes? So acne vulgaris, we all know about acne, right? Here you should know about specifically you have to know about the treatment for mild acne, moderate acne, and severe acne, right? Because there is a huge chart in therapeutic guideline, okay, therapeutic guideline, and it has clearly mentioned it, okay, clearly mentioned about it. Do you remember about this acne chart or not? Because it's a very high yield doctors. They can ask questions from that. Okay, tell me how we should treat the mild acne. How we should treat mild acne, doctors? How we should treat mild acne? Tell me. Okay, here. So in mild acne here, what we should do? Mild acne, what we should do, doctors? Here, 1 minute. Mild acne, we are using what? Over-the-counter topical products, right? Benzoyl peroxide, salicylic acid, azelaic acid, niacinamide plus what? You have to follow the generalized measures for acne, right? Okay, then if the mild acne is not cured by this over the counter topical product, then what you should do? If not sufficiently effective, treat the according to the dominant types of acne present, right? Here, mainly comedone with a minimal inflammation. Mainly comedonal with minimal inflammation, then change to topical retinoid like adapalate, tretinoin, or uh, sorry, what is tributorate? Sorry, triferotine, right? Triferotine. Just remember tretinoid and adapalate or retinol, right? So topical retinoid. So first thing first, if the mild cases were starting, over-the-counter products like benzoyl peroxide, salicylic acid, azelaic acid, niacinamide. Okay. Then, if it is not effective, mainly comedone with minimal inflammation, topical retinoid. If no adequate response after 6 weeks, consider higher dose of retinoid. If using tretinoid, or reassess the dominant types of acne, presence of consider topical combination like benzoyl peroxidase with adapalene, like that. Then, if mainly comedonal with some inflammatory papules and pustules, here they have inflammatory papules and pustules, then what you should do? Topical combination of benzoyl peroxidase and retinoid. Here we have to use combination, right? Combination. If well tolerated but not sufficiently effective, increase the strength of adapalene, right? Okay. After using these over-the-counter topical products, then still not working, then we have to consider about the type, right? Mainly inflammatory papules and pustules with some comedones. Then you have to combine what? Topical combination of benzoyl benzoyl peroxidase and antibiotic, right? So you can use benzoyl peroxidase with clindamycin, right? Like that. Because here mainly inflammatory papules. Here mainly comedonal, right? Here mainly comedonal, but here mainly inflammatory papules and pustules. So we have to add antibiotics as well, right? Then mix both comedonal and inflammatory papules and pustules, and what you change to topical combinations of retinoids and antibiotic. Retinoid with clindamycin, right? Once inflammation has resolved, stop the antibiotic and use the retinoid along for maintenance, right? So please remember. Then last one, if topical preparation is not sufficient, effective at oral therapy as moderate to severe acne. If topical preparations are not tolerated, switch to oral therapy as moderate to severe acne, right? Then they have, I think, yeah, more chart for moderate to severe acne. So how you should treat. So those for the mild cases, right? Then moderate to severe acne, general measures. Then treat according to the dominant type of acne. Like you should think about it's a mainly comedonal or mainly inflammatory. If it is mainly comedonal, then you have to consider early referral to the dermatologist or oral isotretinoid, right? In previous chart also they have mentioned this is not adequate, and if the patient present with moderate to severe case, we have to give oral treatment, right? Here, then you can give oral isotretinoid. For female patient, considered anti-androgenic treatment, spironolactone, like that. And if the inflammatory papules are prior inflammatory papules are then comedonous one, then oral antibiotic, and here for oral antibiotic and topical combination of benzoyl peroxidase and topical tretinoid. Here, three things you are using, right? Benzoyl peroxidase, tretinoid, and oral antibiotic, right? Like that. On female patient, consider anti-androgenic treatment, so spironolactone, like you can give. If acne does not respond, consider a trial in of different oral antibiotic, right? Like that. Please, here the last one, refer to a dermatologist or oral isotretinoin. Last option. Okay, still, acne still not responded. So you these two charts are very high yield. Like if you have time, just go with the e-medicine question. Then you can identify the what are the indications and other key points that you should remember, right? Okay, I hope you understand it. Yeah, we are not directly go with retinoids. Okay, so please keep those things in your mind as well. So what do you know about herpetic whitlow? Herpetic whitlow. Here, herpetic whitlow. Herpetic whitlow. What do you know about herpetic whitlow? Because in November they have given the picture the same like herpetic whitlow, right? So what is it? This dystrophic eczema, right? Because these two, the pictures are almost kind of, not almost, kind of same. So because of that, you should know how to differentiate those things, right? Now tell me about what do you know about herpetic whitlow? Mm-hmm. Okay, due to HSV infection, one or two, right? Mm-hmm. So typical site is single finger or periungual area, right? Mm-hmm. Here clusters vesicles on erythematous base, very painful, and they can be ulcerate as well. Here this is ulcerated one, right? Here these are very painful, right? This is a typical picture. Very painful, right? Yeah, painful. And sometimes patient can present with fever, lymphadenopathy, right? Here it's a painful group of vesicles, right? Here we also can be said. So what do you know about these formifolix or uh, dyshydrotic eczema? We call it formifolix or dyshydrotic eczema because you should know. Mhm. So this dyshydrotic eczema formifolix is a itchy chronic, recurrent, often asymptomatic eruptions on the palms, hands, and fingers and soles of the feet. It is characteristic by small, deep-seated 1 to 2 millimeter fluid-filled vesicles on the site, which resolve after weeks of scaling. It's like a tapioca. You all know, right? You all know about the bubble teas, right? You all know about bubble teas. And do you remember about this tapioca? Tapioca inside it, right? This seems like tapioca, right? Yeah. Here, these are like tapioca, like lesions, right? Yeah. And here, March exam, they have asked about this one, okay? In March 2025. Mm-hmm. Yes, yes, yeah. Here. So please remember. So what else we can see in here? We have discussed this very well in our March discussion, right, doctors? Yeah. These are tiny, deep, clear vesicles, right? Here also group vesicles, tapioca, right? The causes are due to stress, sweating, like other editors, right? So common sites are palms, right? Fingers, soles, right, doctors? Yeah. Then, like features, you can remember it as a itchy tapioca-like vesicles, right? And these are symmetrical. Mm-hmm. Yeah. So what you should do, you can avoid the irritants, right? Or you can give steroid, and you can give the emollients as right. Yeah. Then what do you know about molluscum contagiosum? We have discussed in pediatric rashes few days ago as well. But like this also like the same tapioca like right here. Mm-hmm. That's why I have added. So how molluscum contagiosum? It is a dome shell, right? It's a dome shaped papules with central umbilications, right? Central umbilications. And it's a painless, right, doctors? Yeah, that's how it presents. And a few more things you should know about this oral thrush. So, what do you know about oral thrush? Yes. Okay, we'll do this question. A 46-year-old man present with painless yellowish white patches on his tongue, which have been present for last week. He has 20 pack years smoke in history and drinks 3 glasses of wine a day. He has recently finished course of chemoradiotherapy for T4 lesion of his yeah, defoliation of his right tonsil or scraping the white patch underlying erythema mucosa is seen. Which one of the following is most appropriate initial management? So, what do you think, doctors? Good, Dr. Bhagya. What do you think? Mm-hmm. Yeah, here. Here, this example of oral candidiasis or oral thrush, right? It is condition caused by fungus Candida albicans, which is normal commensal of mouth, but sometimes immunocompromised state. Chemotherapy, prolonged antibiotic use, diabetic mellitus, it can overgrowth and cause symptoms. The first line therapy for mild oral thrush is statin oral drops. An antifungal, it binds to ergosterol, a major component of the fungal cell membrane, forms pores in the membrane that lead to potassium leakage, acidification, and death of the fungus. Right? Why we are not using oral ketoconazole? This is also antifungal drug. Also antifungal, but is used in cases severe oral candidiasis that are refractory to topical neostate. It is inhibit ergosterol synthesis, causing increased fungal cell permeability, right? Mm, okay. And okay, this is the AMC's favorite picture for vaginal candidiasis. Please remember, even I got this exact picture in my exam. Okay, this is the AMC's favorite vaginal candidiasis picture because this came on October as well. Okay, the exact same picture I got in my exam as well. Okay. So because of this, please remember this one. Okay. This is the November question. Picture of vaginal candidiasis, recurrent history after regular treatment. What else management to give? Here we got probiotics, high vaginal swab and culture, colposcopy here. Investigations. Okay. This is from STI Australia. Recurrent candidiasis should be confirmed with vaginal swab for microscopy and culture with specialization. So, due to that, we can go with high vaginal swab and culture for recurrent cases as the first thing. Mhm. Yeah. Here, this is another, and usually the vaginal candidiasis is not always presenting with this curd cheese appearance, right? It can present with this red brick vagina as well. That's why I have added. So please keep this in your mind as well. Red brick vagina, okay? Red brick vagina with burning sensation and like that. Please keep those things in your mind. Yes. That's all, doctors. Yeah. How do you feel about today's session? Have you learned something that you have learned today? Okay. Mhm. Okay, doctors. Yes. Yeah, yeah. Because today is like a very quick revision, right? Yeah, yeah. So because the pictures can, like, even though you have you have seen these pictures, they can be like forgotten during the exam, right? That's why, like, if you see these pictures and you have revised it today, and like after within 1 week you can remember it, right? Yeah. And I will share this PDF as well in the group, doctors. Then you also can like go through it quickly. Yeah. Okay. So, and today is the last day of our revision. I'm not taking tomorrow because you also need your time for your own preparation, right? And like, I wish you all the best for every doctors, and trust your preparation and don't panic. The During the exam week you should be calm, right? You should be calm, because otherwise if you gather everything, like, and this is my personal, do you like don't collect all, like, don't go through all the files, okay? Because there are many groups and there are so many records file, right? Stick to one thing, because otherwise in different opinions, and in the exam, like, if you read different types of files and different answers, right? Different answers, and then during the exam, like, you read the question and you remember this file they have chosen this one, and this file they have chosen this one, and in your mind there should be a, like a war, right? So because of that, the main thing you should, yeah, you should do is, when you got a recall, just revise every possible factor that can come during your exam, right? As example, ADHD. So you should know about how ADHD present, and like, what is the, there's some, it's not a diagnostic criteria, but like, two places should be there, right? The patient symptoms appear before this age, right? And then you should know about, to confirm it, there should be a two setting, right? That, right? Then treatment also, and before starting treatment you should consider about what this patients, is there any substance misuse, oh, right, right? You have to consider even care as well. I'm just giving example, okay? These are the key points you should know when you, like, if you got a question, if you get a question from ADHD, then you should know about what is the first line treatment, and what is the first line pharmacological treatment, and before starting this first line pharmacological treatment, what you should consider, right? Like, because it mainly is stimulant, first line pharmacological, and it affect what, it affect the cardiovascular system. Before that, you have to make sure patient's blood pressure, ECG, and everything should be normal, right? Then if it is not working or contraindicated, then you should know about second line treatment, right? Then you should know about ADHD presented with Tourette syndrome. What is the treatment of choice? Like that. Like, if you can revise topics during the exam week like that, even during your exam, you will get a new question from ADHD. It doesn't matter, right? You know the points and key things, everything, right? Like, every possible every possible thing that they can ask from this topic. Then you feel confident. Even you see the ADHD and you in your mind, you know, oh my god, I have like covered everything for ADHD, so I can do this question. Like if you only just do the recall, okay, this ADHD question they have taken this one in your mind, okay, this is the answer. ADHD question, this is the answer. Like if in your mind, if you keep the things like that, if you see the new ADHD question and you will be panicked, then you can't even remember the theory part as well, right? That's why I'm telling. So even in like day 4, day 5, day 6, the exam topics are repeating, and the sometimes same stem can be repeated. Right? Same stem can be repeating, but the answers, the 5 options are different because I'm telling from my experience, doctor. Okay, I did in day 5 and I got the most of the recalls, but the recalls stem, sometimes the stems are twisted, sometimes options are different because I never see that stems before for those questions. Okay, like that. That's why I'm telling, prepare for the every possible case that they can ask from that topic, right? Then you feel confident. If you get panic during the exam, you can't concentrate. Even though you know the answer clearly, you can't do it, right? Because of the stress, right? You need a clear mind to think properly. And the other thing, the time management, it's a very important. I'm telling, if you're not prepared for that, please, at least today you have time, right? At least take 30 minutes and write down the your time management. And before starting your exam, like right after entering into the your exam center, you will get the this notepad and pen. Then in the notepad, like very in the large letters, you can write down like this minute I should finish this much of question. I'm just telling everything from my experience. Okay, then, like, okay, as example, your time is 90 and you should, this is example, okay, you should cover 90 question, and you according to that your time management. But in the 90 question, you have covered 100 question. Then you feel so much confident, doctor. I am telling this, you feel so much confident. Then that confident also helped you think properly and pass this exam. I'm telling this from my experience. I did my exam in November, and I'm telling from my experience, please do these things. And like the another thing, like don't depend on the answers. Just like it's actually better you go through the topics, you go through the question. Actually, it's better because then you know the possible cases they can ask. But don't remember these questions and answers, because in the exam, even though you know the answer in your mind, okay, in that file they have marked this answer, so that should be the answer. Even though you know the proper answer, like that's how our mind work during the exam. Lot of stress, right? Yeah. Because of that, I'm telling these things. Please keep your keep uh, anxiety away from you, right? Otherwise it's very hard. And during the exam week also, you have time. If you are doing exam in day 4, you have 3 days to prepare, and you have 3 days of recalls, right? So because of that, you can do this. So trust your preparation, and always, like, if you get a recall, even in your classes, like recall classes, like try to search in emails, like try to find related emails question, right? It will very helpful during your exam, okay? Because some points we can't find in the theory, even in TGO, any other guideline we can't find, but in e-medicine they have clearly mentioned that point, right? That's what I'm telling. I'm not taking too much time because these are very important. That's what I'm actually telling these points. Yeah. So, and finally, I wish you all the best, doctors, and like you can share the recalls in our group as well. Then I can also help. So yeah, you can do this. I'm always here for you. Like if you feel stressed or anything, just text me or ask me. Like we can do this, right? You're not alone in here, right? I'm also here. So we have our March group as well. So we can do this, doctors, right? And never think about any negative things. You can do this. You have work hard, always manifest. You have worked hard, right? You have done so many commitments, especially the doctors who have small children in your home. I don't know how to tell. Like, I know, I actually personally I don't know, but I heard so many stories. Like, they have so much commitment with small babies, and especially uh, so toddlers, right? So you have done so many commitments, and everything will be worth at the end, right? So because of that, these are few more days, right? Few more days after your winning is confirmed, right? Yeah. Then we have to wait for the result days, and always manifest your winning only, right? There's no don't keep any negative things, right? Don't keep any negative things. You can do this, right? You got this. Yes. Yeah, doctors. And all the best. Study well. Yeah, you can do this. And thank you so much for joining live classes. And yeah, I believe everyone can do this. Okay. Everyone, each one of you can do this. So yeah, and make me proud as well, right? Yeah. Because I also have, I also doing a huge commitment for you, right? So make me proud, right? Okay. Yeah, yeah, doctor. So, yeah, let's finish the session. All the best. You got this, right? You can do this. Right, doctors? You have worked hard so much and manifest only your winning. Okay, yeah. Okay, I'm going to
Thank
stop
you
the
so much for
recording.